who has 5 minutes completely uninterrupted. Amanda.
All right, I'm so excited. 5 minutes uninterrupted. This is joint work with Jason and Peter and Zach Bleemer. And at a high level, the question that we're going to ask in this paper is essentially, can we measure PCP quality? Okay, sort of broadly for the Medicare population. And how should we think about this in context? So this is both a measurement paper and speaks to some of those higher level questions as well. And so thinking about the literature and what folks in this room have been working on, there's a lot of growing evidence that there is tons of variation in outcomes in healthcare among observably similar patients that are really reflecting causal differences across providers as opposed to just patient sorting. Now, the interesting thing is that we know this across a bunch of different settings. Obviously, the place where we've potentially spent the most time is thinking about hospitals, but we've also looked at this when it comes to nursing homes or insurance plans. You can think about geography being a version of this. And we've also thought about this a little bit in the context of physicians. Now, where we got started on this paper was thinking about our plan effects from our previous paper and thinking about how to explain that and what role physicians could play. And so what we're going to try to do today is sort of extend and synthesize this work. So the first step is going to be building validated value-added measures for the universe of PCPs in Medicare. Then we're going to place them in a common framework where we can think about both variation in physician quality and variation in hospital quality and aggregate that up to the plan level. Ultimately, we want to ask, can we determine who the good doctors in Medicare are? And if we can determine who we think have better causal impacts on patient health, are there either market or regulatory mechanisms that might direct patients towards those doctors? Okay. So why PCPs? Okay. So I think of PCPs as clinically and economically central. If you don't mind a sports analogy, you might think of them as sort of the quarterbacks of the healthcare system, which will come back. And so they're going to serve as gatekeepers for thinking about referrals and prescriptions and chronic disease management. The existing quality measures that we haven't validated in ways that we would particularly like, so we want to think about whether or not those quality measures are particularly useful. Okay. We also know from previous work from folks in the front of the room that about a third of geographic differences in utilization can be explained by doctors, and so this could be a potentially useful path forward for thinking about uniting these ideas. Okay. Furthermore, if we think about what we can do about it, if we can construct and validate measures of PCP value added, well, there are lots of market mechanisms and policy choices that might potentially shape the allocation of PCPs. So if we think about network formation, one thing that's interesting is that within Medicare Advantage, which I'll talk about in a second, the average MA plan is going to include only about half of PCPs. So this is a choice that plans might make to exclude some physicians from their networks. Okay? By contrast, hospital networks in MA, at least, are pretty broad. Okay? So this is potentially an important dimension that insurers, an important lever that insurers have to deal with. Okay? Furthermore, in other work that I've done, Ashley's done, other folks have thought about, market organization of these clinicians is really changing. And so as we're thinking about the ways in which these physicians are organized, that could be potentially useful as we think about not just, say, price effects, but quality effects as well. Okay? So at a high level today, we're going to ask 4 basic questions. The first question is really that measurement question on which everything else hangs, which is, can we construct and validate measures of PCP value added? Okay? Once we make some progress on that first question, we can ask some additional questions that are potentially interesting. These are not the only ones that are interesting, but they're the ones we'll talk about today. So the second question is, how should we think about quality and cost trade-offs? Okay? We can think about what observable characteristics might predict PCP quality, and we can think about how easy or hard it is to predict PCP quality. And then we can also think about, all right, at a higher level, as we're rolling up physician quality into plan networks, how much of plan network quality can be explained by the quality of the PCPs in that network? Okay, I've got 13 seconds to tell you what I find before you're allowed to ask questions. So let me tell you what we're going to do. We're going to find that we do a decent job constructing these value-added measures. We're going to validate them using moves and retirements, as other folks in this room have done in the past. If it's meaningful to you, we're going to get a forecast coefficient of around 0.7 and lots of variation in PCP quality. Interestingly, I'm going to show you that lower mortality PCPs are also lower cost, so they're spending a little bit less, okay? If we look at what predicts quality, training really does seem to predict quality here, but quality is somewhat hard to predict. And when it comes to those plan networks, the quality of the PCPs in the network is much more important than the quality of the hospitals, which I'll show you, okay? Okay, Amy.
Mortality as much as the next follow, but like mortality over what horizon? I'm just trying to think, is there a higher, it's hard to measure PCP quality, but mortality may not be the optimal one, especially in the short term.
Completely agree. So what we're going to do is we're going to measure mortality in moving 12-month windows, and we can play around with that window a little bit. I agree this is not the only measure we care about, and in robustness you can broaden that window. There's sort of a trade-off with doing that. What we'll then do once we get to the characteristics is we'll think about other measures that like Medicare might put together in terms of MIPS and see how correlated these things are.
I guess another way of thinking about the question is, I could be a really good PCP, and I'm very attentive to early warning signals and refer them out, but I'm in a place where
That doesn't do me any good.
Yeah.
Yeah, so I think there's an interesting question. So if I were a PCP and I looked bad on this measure, that's exactly what I'd complain about, right? And that's totally fair. A counterpoint might be that one of the things that a good PCP might do is direct you to the best possible specialist. That might vary. The availability of those specialists might vary across geographic areas. We'll always be looking within an HSA, though. And so take that for what it's worth. So we don't want to call you bad because you practice in a place where you don't have access to high-quality specialists.
Awesome, thanks.
Love it. Okay, so let me tell you a little bit more about the institutional setting. We will be using both traditional Medicare data and Medicare Advantage data for slightly different things. Okay, so the first half of the talk or so, we'll look at traditional Medicare, where people are in fee-for-service, they have a near universal provider network. We're going to have detailed claim data, and we're going to use this for the quality measurement piece. So the way you should think about this is the value-added measures we're going to construct for folks that are in traditional Medicare. Then we'll do things like look at expenditure in traditional Medicare. We'll also look at physician characteristics. Then when we're thinking about that network piece, we're going to think about Medicare Advantage, which is now about half of beneficiaries, where we know from previous work that plan quality varies widely. One of the reasons that might be true is selective contracting among certain kinds of providers, and we'll leverage that Medicare Advantage data to think about those questions of network adequacy. All right, let me give you some summary statistics from the data. So the first thing we're going to do is we are going to assign people to a primary care provider. That is a little bit tricky, and so we are going to be able to assign a good chunk of folks that for which we observe 20% in the carrier file to a PCP. They look pretty similar to the Medicare population as a whole, although they are slightly older, whiter, and more female. In part, that's because they are all in fee-for-service, and good. Then what we're going to do is we're going to look at the PCPs that exit a market. Okay, now a PCP could exit a market, which we'll call a termination of that relationship, for multiple reasons. This could be because they retire, because they move across HSAs, but in many cases we will see that relationship being severed, and that's the variation that we're going to use to validate our value-added measures. Okay? So the important things to take from this wall of numbers is, first of all, if we think about the fraction of people that switch doctors, it is generally fairly low. The exception is in those time periods in which you have a PCP that exits the market. Then you are essentially forced to switch doctors. If you are forced to switch doctors, then we can look at the variation, the difference between the doctor that you had before and the doctor that you had now, and use that to validate our estimates. Okay, we're going to use the timing of those exits and retirements as opposed to comparing what's going on in the first column to what's going on in subsequent columns. Okay? So the first part of the exercise is going to be constructing and validating those value-added measures. So let me tell you how we're going to do that. We're going to proceed in a series of steps. So the first step is going to be essentially constructing a candidate measure, okay, for value-added. We're going to do this in a pretty straightforward way, where we're going to run a regression, okay, where on the left-hand side, we have a one-year mortality indicator. Okay? Amy, we can do it in different time horizons if you'd like. We're going to regress that down, okay, on essentially a set of PCP fixed effects, as well as patient observables. So we'll have things like age, sex, race, dual eligible status, as well as things like chronic conditions, because remember, we're going to observe the claims for these folks. We're also always going to control for HSA year fixed effects. Okay? So the way you should think about it is that we are comparing doctors only against other doctors in their own HSA. Okay? What are we going to, yeah, sorry. Yes. So you might be concerned that what the good doctors are good at doing is making their patients look really sick, you know, either by accident or by gaming.
To get the full story, like, I think if you have a good PCP who sees you a lot, like, you're more likely to end up with a lot of diagnosis codes attached to you than if you have a PCP that you only see very rarely.
I completely agree. I think that's completely valid. We've thought a little bit about that and have done it with and without, like with different levels of HSA or with different levels of chronic condition fixed effects. It doesn't seem to matter that much, but I broadly agree with the concern. I think it's definitely something that's worth kicking the tires on a little bit more. Yeah. Good. Yes, we know that because of Adrian. So yes, there is. I don't actually have that coefficient in the slides, which I realized when I was chatting with her this morning. But yes, we're not gonna need that for the procedure that we're going to employ. There is just going to be a termination effect. We are going to be differentially comparing what happens if your good doctor exits versus a doctor that we think is bad exits. Okay. Good. All right, so then what we're going to get from this procedure is a set of what I'll call mu-Ps. Okay, these mu's are essentially like mechanically PCP fixed effects. We're going to think of them as sort of within HSA risk-adjusted mortality. We'll then employ sort of standard empirical Bayes methods to shrink them and correct for noise. Okay, so how should I think about what these mu-Ps are? Well, they're going to capture variation across PCPs in the same area among observably similar patients. Now, we could all spend the rest of the 40 minutes coming up with stories for why these are bad measures, and there's all kinds of selection that remains, and so I want you to hold on to those for a second because we're going to think about validating these before we take them for a spin. Okay. When we look at the distribution of this observational mortality measure, what we see is a lot of dispersion. Okay, so the beneficiary weighted standard deviation is around 3.1 percentage points, which is pretty big, but comparable to other sources of variation in both expenditure and across hospitals. Okay, so think there's big variation across doctors as measured by this sort of risk-adjusted mortality measure. But of course, we don't care unless that is truly reflecting something about the causal effect of those doctors as opposed to other factors. Okay? In order to think about that more carefully, what we will do, okay, is we will estimate a forecast coefficient. Okay? So let's just think about what we would actually want here and what we can actually get from the data. So what we might actually want is some beta P, where beta is the true causal effect of a given physician. Okay? This is what their mortality rate would be if their patients were randomly assigned. Okay? We are not going to get that. Okay? We're not going to get that for any clinician, let alone all of them. Instead, what we're going to do is we're going to think about projecting those betas down on mu, this candidate measure that I have shown you, okay? And to see whether that mu predicts the true causal effect. Okay? And so the way you should think about this is we can write beta p as lambda, which is going to be the forecast coefficient, times mu p, okay, which is this value added measure I proposed, plus eta p, which is going to be an error term. Okay? Under the assumption that eta p is orthogonal to mu p, this forecast coefficient is going to tell us something interesting. In particular, if we get a forecast coefficient close to 1, you can think of mu p as being on-averaged, unbiased for the causal effects of a given PCP. Okay? But then the question, of course, becomes, how are you going to estimate this lambda parameter? Okay? So we've taken the problem from estimate 20,000 different fixed effects, okay, to estimate one number, okay? But now I have to tell you how we're going to estimate that one number. Okay? So what we're going to use is quasi-experimental PCP estimates as an instrument for the change in the mu of the PCP that a given patient sees, okay? Controlling for both those lagged mu's, okay, and those direct termination effects that you're right to worry about. J is a typo.
Okay, sorry.
J should be P.
I wasn't trying to be annoying. The live view of the prior PCP.
Yes, exactly.
If there's a potential that I saw the good Dr. Amanda, and even though she's now retired and I'm seeing the bad Dr. Peter, it's having your
Exactly. Yeah, we're gonna control for that.
Patricia, bad PCP.
Fair enough.
I mean, so say we all. So yes, so that should be mu p. That's just hangover from the last paper. All right, so let me tell you the intuition, which Amy has already previewed. Let's think about a patient who's seeing a high mu or a bad PCP last period. Okay. If that PCP doesn't move or retire, we already saw from that summary stats table that the most likely scenario is that you're going to see the same PCP next year, right? By contrast, if that PCP exits or moves, then the patient is going to switch just by mean reversion, okay? They're going to end up with a PCP that's more typical in terms of mu. Okay? You could come up with stories for why that won't be true, but I'll empirically validate and show you that they're going to end up with a more average-looking physician. Okay? So what should we expect? Well, we know that the mu, okay, of the PCP that patient is seeing is going to fall. If mu is picking up something that's causal, that cohort's mortality that is switching from what I think is a bad doctor to a more average doctor should also fall. Okay? There should be a symmetric story if you are seeing a doctor that I think is particularly good and that doctor exits. We should expect that cohort of patients who are seeing more average-looking doctors to be more likely to die, and it's that difference in slopes that is going to identify lambda. Okay? Good. All right, so we're going to need a bunch of things. So we're going to have an instrument for lambda, which is the lambda from last period interacted by termination, and then I'm going to have some validation. Yeah?
I'm reminded of Adrian Savvy's paper in the back about people's PCP leaving and people getting primary care from specialists and not from primary care. How do you deal with that here?
Good. So this is sort of embedded in the how do I assign you to a PCP problem. So we are looking for people that then subsequently see another PCP, and then we have a different category that is essentially the no PCP category. And so that's embedded, but we're not going to use it.
So you're not including specialists who are also delivering primary care as pseudo PCPs in the analysis?
I'm not going to include, I think that's a valid choice. You could imagine doing it either way, but we are going to choose not to include those folks in the exercise.
Sorry. So this was super clear, but it made me realize that I'm a little confused. I understand how this approach that you explained could identify the sort of
share of a doctor's, risk-adjusted mortality outcomes that's causal versus, unobserved stuff. But I thought you were saying that but you could be getting that very well and still not be getting your lambda of 1 because because a doctor's risk-adjusted mortality might involve both the unobserved, and I thought the whole point was even if you didn't get a lambda of 1, you could still be okay. So that's what
I love this comment, Amy, because we're not going to get a lambda of 1. So,
But I guess another way of saying it is, right, I wouldn't have thought you would, and I wouldn't have been concerned, but given that you teased me with that lambda of 1, thing, what can you do to verify that you're getting a unbiased forecast?
so I'm not going to make that argument to you.
Okay, great.
Okay, and so you're about 3 slides ahead of me. What I'm going to show you is that mu does have some predictive content for thinking about these betas that we have given up on measuring, but it's going to be far from 1.
But that's not necessarily a problem.
No. It just is. Yes. Sorry, I just wanted to give you some context for what lambda meant. Yeah. Sorry, Tim.
If your ultimate goal is to characterize, the quality for a provider network or something, why restrict yourself to risk-adjusted mortality as the predictor rather than use just everything that you can project using this method onto the causal PCP event?
Good. I think we will get there. I will not quite get there today. What I'm going to show you is that there is some information in this risk-adjusted mortality measure. There might be other things that are potentially valid that are correlated with it, and I'll show you that as well. And so then you might end up with the question of, if I wanted to put together the best PCP network I could, what is the information that I will use? And I'll have some simulations that speak to that, but we probably won't go as far as you want, and I'd love to hear what you think afterwards. Yeah.
I'm wondering what we know about why PCPs move. I understand there's one possibility, but could it be the not decision that move would be difficult to channel?
That's possible. So one thing that we see in practice is that their panel sizes tend to get a little bit smaller before they move, which is consistent with a bunch of different stories. I think it's worth thinking a little bit more about endogenous mobility for sure. Okay, yeah, Joe.
So I'm thinking about the patient side, and so let's say Edward's PCP retires, and he's very effective and motivated to find a new PCP. My PCP retires, and I'm not so effective, and I delay care and so forth. It seems to me you've got a very assumption here that the unobservables on the patient side and effective searching are similar.
Yeah, I don't think it's buried. I think it's 2 slides out. I think this would be a violation of what we call our fallback condition. And so this is why we're going to want to control for things like, are physicians in the same clinic, right? So maybe you just go to the doctor that's in the same clinic. That would be a violation of an assumption that I'll show you on 2 slides. And I completely agree. We don't have a ton of evidence for the type of story you're describing, but I think it's a valid
I can
concern.
tell you one personal anecdote. My PCP retired, and his partners in his group agreed to take his patients.
Yeah, so I'm going to control for that. I'm now going to call that the Joe control. So we will control for are you practicing in the same clinic, because we would be worried about that exact type of concern, for sure. Okay, good. That's our fallback condition, so I need 2 more slides to get there. The first thing I want to show you is essentially a first stage. There's going to be a series of pictures like this, so let me just tell you what's going on. On the x-axis, we have the lagged observational mortality. This is the mu of your doctor last period. On the y-axis, we have the observational mortality of your doctor this period. What we see here is that for folks that are seeing PCPs that don't move or retire, that we don't observe these exits for, this line is pretty close to the 45-degree line, whereas for folks whose physicians exit, it's way flatter. It's this orange line, which is saying if you were seeing a particularly good doctor, you end up with a more average doctor, and also if you were seeing a particularly bad doctor, you end up with a more average doctor. Okay? Then we want to look at both balance and fallback. I only need 2 slides, Joe. And so balance is saying, essentially, are the people different across folks in whose doctors exit or not? Okay? as we look across observational mortality? And the answer is no, not really. The slopes of those lines are pretty similar. It's not perfect. We're working on it. The fallback condition is saying, are the second choices different? This is exactly what Joe is worried about, okay? And so what we're going to do is we're going to essentially say, are the types of doctors that people end up seeing, do they look different in terms of that eta error term? Okay, we don't have any evidence of that, but as I alluded to with Tim, it's kind of hard to predict this measure, and so you might be worried that this is potentially a little underpowered, okay? The last thing that we're going to do then is take what was essentially that first stage picture, and instead of having observational mortality on the y-axis, we're going to have actual observed one-year mortality for this exact cohort of people. Okay? What you see when you do that, which you should think of as the reduced form, is a difference in slopes across the blue and orange line that echoes what we saw in the first stage. Okay? What that suggests to us is that some of this variation in beta can be predicted by this variation in mu. So we're going to formalize that in the IV framework, where we're going to run that two-stage least squares formally. Yeah?
Amanda, because the instrument is the lag doctor quality, if there's any long-run effects of your previous PCP, would that attenuate the lambda coefficient that you estimate? Because some of what you're capturing is.
Well, so remember, we're going to control for.
How can you control and use it as an instrument?
Because it's the mu interacted with the termination effect that's the instrument. That's what's excluded.
Right.
And so we're going to have that across the board. I think I'm not quite understanding.
If they die, that's an absorbing state. So you don't have a pre-period and a post-period.
Agreed.
So if you only have a post-period, how can you control for the previous guy's PCP and interact the lag PCP quality with the information?
I don't think I understand your question, which I would blame on me, except Peter also looks a little confused. So can we talk about it right afterwards? Amy's going to chime in to.
I think what Layla's question is, which was also mine and Ben's, was sort of you want to control for the lagged causal effect of your prior PCP. But if your prior PCP himself never retired or had patients that were coming for, it's like a connected set issue from doctors who retired or moved, how do you get the causal effect of your prior PCP?
Okay, good. I see your question, and I want to think about it a little bit harder. So same answer, which is let's talk this afternoon. But good question. Thank you.
Amanda, how do you think about, I have Mike working on this side, the prior literature on patient-doctor match effects?
Yeah, so this is a great question. So we're going to be looking on average. Then you could think about heterogeneity as well, which could potentially be important and start to speak to some of these match effects. We're not going to get there today. Not because I don't think it's important, but because I'm going to run out of time. Okay. Good. All right. So putting it all together, what do we find? Well, we're going to have a pretty strong first stage, which is, you should expect that because I showed you those differences in slopes from the first panel. We are going to have some small balance failures. Once we control for stuff, they're not meaningful, but in that first column, if you want to deduct 0.07 from all of my forecast coefficients, I'm okay with that. This fallback Joe concern is something that we don't have strong evidence for, but might potentially be underpowered to detect. And then in terms of the forecast coefficient we're going to get is not 1, as Amy was worried about, but instead is going to be around 0.7, okay? And so what that's going to tell us is that variation in mu does have some predictive power for causal effects, but of course it's not unbiased for any individual's beta p. Okay, so we're going to do a decent job, but we're not going to get a forecast coefficient of 1. Yeah.
Sorry, I may have missed this, but you guys just bring it to a sample, to a period of working with your PCP for at least some time? Because there's maybe sometimes one visit a year, and it takes some time for the effect to happen. Is there any restriction like that in the pre-period?
There's no restriction like that in the pre-period, although remember that these relationships are pretty sticky. And so because they're pretty sticky, absent these exits and retirements, I think I'm maybe a little less concerned about this than you are.
The number of years they work together
We could construct that and control for it, for sure. I'm assuming Peter's taking notes. Okay. Good, all right, so we have a decent measure, okay, for thinking about PCP quality as sort of proxied for by this forecast coefficient of around 0.7. Okay, and so now let's think about what that means. Okay, so the first question we want to ask is there a quality cost trade-off at the physician level? Okay, so essentially what we're going to do here is we're going to replace this 1-year mortality measure, okay, with log spending, okay, on the left-hand side of the regression, and run the same IV. And the question this is asking is, these doctors that I think are good, are they spending more or less than the doctors that I think are bad? Okay? And what we see here is that a PCP that has a 1 percentage point higher mu actually spends about 3.5% more. Okay? So the lower mortality PCPs are also lower cost. Now, how should I think about that? Well, the way I think about it is, if Joe Doyle were here, what would he say? And so I think this is consistent with the sort of older Joe Doyle paper where higher quality ER docs use fewer resources to get similar outcomes, right? It's sort of the through the looking glass version of that, which is saying that the doctors that I think are higher quality are actually spending a little bit less. Yeah.
Do you know the marginal services on which they perform fewer services?
No, but we're working on it. So you could deconstruct this into, are they prescribing more drugs? Are they keeping you out of the hospital? We think they might be keeping you out of the hospital, but we're totally doing that now. Okay? Yeah.
So maybe I didn't understand in the first paper for this, but what do you have? So to project stuff onto the PCP effects, what do you have to assume about the selection bias from each PCP? You have to assume it's like totally level independent of their causal effects? I'm just trying to think about, is that what the assumptions about the selection bias you're taking out of the PCP effect?
I think you're asking about the fallback condition, which sort of says that when PCPs exit and folks switch to their sort of fallback PCP, they're not systematically different in terms of that residual. Is that what you're asking?
No, I'm asking more, so you're going to use lambda times the observational as a proxy for the work effect. So
Yes.
You need to assume that whatever the selection bias is that lambda's taking out is.
Oh, do we need to assume, say, a constant lambda?
Yeah.
I think you think of it as like a best prediction. And so if we're trying to predict quality, lambda times mu is going to be sort of our posterior
best guess.
prediction of quality.
But if selections correlate with mu, then.
I think on average it's okay, but you wouldn't want to do nonlinear things with that, basically.
Yeah, good question. Thank you. Okay, so now we get to have a little bit of fun. We can think about what predicts PCP quality. So who are these good doctors? Now, Zark's question is the perfect segue into thinking about this, because what I'm about to tell you is a bunch of characteristics that are correlated with mu. And that need not mean they are correlated with beta, okay? But we have some evidence that they're correlated with mu. Okay, so take that for what it's worth. We are typically going to be underpowered to run the same IV, although in some cases we probably can, and this is something that we're working on. Okay, so what's correlated with mu? So we're going to project mu on a rich set of physician characteristics. We're going to have things like demographics. We're going to have training and credentials. We're working on practice characteristics. And we can also look at other potential measures, whether they're from the patient side, do patients rate them well in online ratings, or alternatively Medicare-based measures. Okay, what I'm going to show you is a bunch of bivariate OLS regressions, and then we're going to throw the kitchen sink at it to see how good of a job we can do predicting physician quality as measured by mu with all of the characteristics together. Yeah?
I'm worried about like super heavily correlated variables. In particular, like I would be interested to know whether MCAT is predictive or med school rank is predictive. Like those seem relevant, but are incredibly highly correlated.
Sure are. So let me tell you what we find, and then we can sort of say, all right, if you throw like a neural net at this, what would it say? We are not going to be able to say, oh, you know what? When I'm looking for a PCP, either for myself or for my parents in the Medicare population, I want the guy who got a really high MCAT score but went to a just okay medical school. That's not something we're going to be able to say. But what I can say is that if you went to a medical school that on average has a higher MCAT, you on average have a lower MIA. Okay? And this is going to be consistently true across a bunch of different variables that are capturing something about human capital. Okay? And so that's true for MCAT scores, for ratings, which of course, as Judson correctly points out, are going to be highly correlated, so perhaps this should not be surprising. One thing I did find a little bit more surprising is that the MIPS scores that Medicare is going to put out are highly correlated with MU. Okay? If you spend any time sort of digging through how these are constructed, they seem quite gameable to me, and yet they seem to have some predictive power. Also, things like online ratings also seem to predict MU. Okay? You can also look at demographics. And so you can make of this what you will. There are a bunch of different demographic characteristics that also seem to be correlated with MU. Yeah, Justin?
Should I read these as conditional on each other? So if you don't-
No. Each is a bivariate.
Okay, thanks.
Yeah. Yeah.
So, to recognize the earlier question, like, what if you just put all of these in the termination regression and then didn't have to, correlate them with the means, but could actually correlate them with the betas? I guess the main issue with that is that,
The issue is power.
yeah, power and the terminations are highly selective. But I guess that would, for some of these at least, you should be able to see something and maybe get something.
You could, it's an IV with like 5 endogenous variables though, so that's not.
So we've done this a little bit, and we did this in the previous paper. We can push on it some more and see what we can do. I think your point is well taken. I just don't know if it's super easy to implement. Yeah, Layla.
I like briefing on the DOMD thing, but I was wondering if you
Oh.
could further take on like the NPPA. I mean, I know there's an incident billing and they're maybe a little harder to find, but I think in some state, like, you can find them.
I think it's super interesting. I think the billing rules changed during our time period. And so, yes, totally fascinating. Not sure if we can totally pin it down, but we can chat some more for sure. Yeah.
How do you think about selection due to recruiting content from PCP versus if you're high ranks?
Where's Molly when you need her? We're going to work on that. We are going to swap measures. If you saw Diane present in the spring, you might exactly be worried about who selects into medicine. We're just going to swap measures and see what it does in this exact regression. Okay, I'm going to move along because what I want to get to is thinking about how this matters sort of at a broader level. So far, we think training matters. Okay. The one thing I haven't told you so far that Judson alluded to is like I don't know whether I care about MCAT score or med school. You might care about both, but even if you throw the kitchen sink at this, it's going to be quite hard to predict this MU measure. And so observables are only going to explain about 5% of the variation in our value added measure. So this raises some interesting questions. If it's hard to predict MU, it's probably hard for consumers to find these high quality doctors, and it might also be hard for insurers to construct their networks in such a way that they are directing patients to higher quality doctors. So we want to connect this to that higher level question of, can we think about insurers as playing an important role in putting together networks of high quality physicians? Okay, for this we're going to turn to Medicare Advantage. Okay, yeah.
Sorry, really quick question. I guess you guys are going to assume that the quality from traditional
Sure are.
care is the same.
Yeah.
I guess, do you want to talk about that just for a second? I know you understand why that.
Yes, so you could be concerned, okay? So what I've told you is that I have a decent measure of value added, okay? But that value added measure is for a particular population, Okay, it's validated in that same population. And also, I'm not accounting for important heterogeneity, and especially if you think there's differential selection both at multiple levels, both into MA, into different plans, into physicians, you might be super worried about this. So one thing that you might imagine is that I will spend a bunch of time constructing a measure of PCP quality at the network level, and it will predict nothing about plan quality. Okay? In practice, that's not what we're going to see. Okay? So I think everything you just described, we're right to be worried about and would attenuate our estimates.
Are you guys able to think also about, there's going to be some patients in the data, some physicians who see very low TM patients and very high MA and vice versa? I don't know, I'm not smart enough to figure out yet how, but I think you can use that.
I think you're right. Yeah. I also am not smart enough on my feet, but I want to think more about it. Yeah, Bobby.
One way to think about validating you is to say, find a relationship that we think must be true. So going to a good medical school versus not as good may not be true. But 1 year of experience versus 5 years of experience, it has to be true.
And it is.
So I lived it. All right.
So yes, but disentangling what about your experience makes you a great doctor is more challenging, but experience absolutely does matter, and I just skipped over it. Okay. I want to keep going because I got 5 minutes left. And so the first thing I want to do is think about Ben's question. So if you're worried about Ben's question, you might think this is all well and good. You've constructed something that's completely useful within traditional Medicare, but it doesn't apply more broadly, let alone in the MA population. So what I'm going to do is I'm going to construct a measure of MA network quality by looking at both their hospitals and their PCPs. I'm going to call this an inclusive value, which is basically right, but the IO people can complain about later. It's a weighted average of the quality of the folks that are enrolled in an MA Plan C. Okay, we're going to do this for hospitals using their list networks as well as MedPAR data. We're going to do it for PDPs using this PDE-based methodology. So it's basically saying the doctors that are prescribing things to these folks. Okay? Then we're going to regress plan level observational mortality on inclusive values. When we do that, we see that the plans that we think have better PCP networks, okay, are better plans by the measure in our previous paper. The relationship is far from 1. You shouldn't expect it to be 1, but we get a relationship between these two measures. And by contrast, if you look at the same measure for hospitals, it is a much weaker relationship. So if we're thinking about what might predict plan quality from our previous paper, it seems to be much more about the PCP network as opposed to the hospital networks. We think that makes sense because remember, PCP networks are much more restrictive than plan networks, so we're going to have more variation across plans. Yeah, Maggie.
Is that, have you looked at that? If it explains network fusion of the plans, conditional on all these other signals, does it seem like the plans are just sort of, they're looking at the big score and they're like, this is who we want, as opposed to they have additional.
Yeah, so there's two related good questions here. Like, what is our best predictor of PCP quality? And does the market kind of reward that? Are you more likely to be included in a plan network if you perform better according to these measures? We have done the first one, but not the second one, but it's something we should work on, for sure. All right, in my last 2 minutes, I want to show you some counterfactuals that will help you put some of these numbers into context. So now that we have these value-added measures to start to answer some of the questions that Maggie alludes to, we can think about doing something like, what Chetty Friedman-Rokov do, which is let's just kick the worst 5% of doctors out of Medicare and see what impact that could potentially have on patients. Now, to Zarek's point, what we're going to do is we're going to kick those high mortality doctors out. This is obviously infeasible for many reasons. Okay? Then we're going to look at the change in quality that the average person sees. We'll multiply that by lambda. That's our best prediction of the mortality effect. Okay? All right, if we do that, and I think of this as an infeasible benchmark, the system-wide removal of the top 5% of PCPs as measured by mu, leads to a 5.4 percentage point reduction in mortality. Now, we could think about something that is more feasible, which is to say, all right, if you're a plan, okay, if you're the United plan in a given area, it's much easier than, say, CMS to kick what you think of as the bad doctors out of your network. And so if we dropped the top 5% within each plan, okay, we would get about 3/4 of that system-wide gain. We get a reduction in mortality of around 4.15%. Now, there's a couple of problems here, okay? One problem is about information and one problem is about incentives. I said it's kind of hard to predict my mu measure, and it might not be even, to Tim's point, the thing you really care about. So the question is, if I just gave you these observable characteristics, okay, how well could you do relative to this benchmark? And then also there's an incentive question. Now, I already told you that the lower mortality PCPs actually spend less. So as a plan, you might want to keep them out for that reason as opposed to the quality gain reason, okay? So let's think about both of those thought experiments. Because it's really hard to predict mu based on observable characteristics that I showed you in those slides, if you drop the top 5% of docs by mu hat, our best prediction of what mu is, you get relatively small gains. But if you drop the high spending physicians, which you could imagine plans have a pretty big incentive to do anyway, you get a decent quality gain, okay? All right, and so we've talked about this a little bit in the last minute, 30 seconds. I will say what we have aimed to do today is build and validate PCP VAM measures. Okay? And then think about what this means for how we think about healthcare markets more broadly. Going forward, we will take all of your suggestions and take them to the data. We'll also think about things like equilibrium effects, some of the questions Bapu asked, and how to optimally design a network. We're also going to connect this to some tax data to think about both income and responses to the tax cuts under the Trump 1 administration. All right, thank you so much. I look forward to chatting more about all of your questions going forward.
Thank you, Amanda. Let me invite Great. So just like yesterday, we have one egg timer session today. Each of those egg timers will get 10 minutes completely uninterrupted, no questions due to the short time limit. However, we have a thick 30-minute break after these 4 egg timers, and we're going to place them strategically around the room. So Munir Karaja will go first, and after the 4 talks, Munir will be back in the far corner of the room. Hitoshi will be second, and we'll put Hitoshi after the 4 talks right here in the bull ring. Edward Kong is the third, and we'll put Edward right here on this side of the room, and then Brandon Churchill will stay right up there at the podium for anybody who wants to talk with any of these authors after their wonderful egg timers. So we'll start with Munir. Munir, the floor is yours.
All right, thanks so much for the invitation. I'm Munir from Uppsala. My excellent co-author Akib is here in the audience as well. In this paper, we're going to ask the question how migrants cope with conflict erupting in their country of origin. So we're motivated by 2 facts. The first is the rising number and severity of state-based conflict since World War II. The second is the large and growing international stock of international migrants, so over 300 million individuals worldwide, many more than the number of international refugees. From the literature on refugees, we know descriptively that they face a lot of mental health challenges from their direct exposure to conflict. And there's some evidence that this also affects them negatively in the labor market. But we know much less about how conflict affects the broader diaspora. And so that's what we're interested in. Like a super short theory of how we're thinking about potential effects here is, in terms of how mental health might be impacted, we have no reason to believe anything that it's going to be negative. But in terms of the labor market, it could be ambiguous. So you can imagine a positive labor market response if people in the diaspora need to help family out who are in direct danger. But you could also imagine a negative effect if sort of the mental health shock dominates. In practice, what we're doing here is we're going to study Russia's full-scale invasion of Ukraine in February of 2022 and study its impact on Ukrainians who were abroad at the time, right? So we're not studying the refugees, we're studying the diaspora. The data that we're using is Swedish quarterly admin data on all mental health prescriptions and labor market outcomes. The sample consists of any foreign-born individual who was living in Sweden throughout the entire period of 3 years before to after. So there's no selection in or out of this sample. And we exclude Russians and people from Poland, the Baltics, etc., because we can expect some contamination effects there. And it's a very simple matched two-way fixed effects event study where the treated are the Ukrainian-born. And the controls, we pick for each Ukrainian 2 individuals who are matched on age, gender, years in Sweden, their visa status, and so on, determined before the war. And we achieve a nicely balanced sample of about 9,000 Ukrainians and twice the number of other migrants from about 100 different source countries. So I'll jump straight to the results. The main result here is, so the outcome here is redeeming, going to the pharmacy and picking up any prescription for mental health drugs. It increases by about 30% in the first quarter of the invasion. It decreases but remains statistically significant throughout the period, and actually it shows some signs of increasing towards the end, so this is 3 years later in 2024. And most of this effect is driven by new users, so people who don't have a prior mental health prescription. If we split this by the type of medication used, panel A shows that the sort of immediate uptick is driven by what we call immediate effect drugs. So these are anti-anxiety and insomnia drugs. However, over time, we see this slow upcreep or increase in the take-up of antidepressants, which is consistent with the fact that you're only supposed to be prescribed these for lasting symptoms, right? And as you can see, the trend is increasing throughout the entire period. And this is driving the sort of increase that we saw at the end of the previous graph. Okay, so if we turn to earnings effects, what we see in the first quarter of the invasion is in fact a negative effect on earnings. This is also mirrored in an increase in sick leave applications, just in that first quarter. Sick leave then decreases below its pre-invasion mean, whereas, as you can see, earnings increase consistently over this 3-year period. So we think that Ukrainians are clearly working more and potentially working more despite being sick because they're not taking sick leave. And this represents about a 3 to 4% increase in their earnings. So one other way that earnings can increase is by reducing reservation wages. So the way that we're going to tackle this is by, in both of these graphs, I'm restricting the sample to individuals who entered into unemployment in the year prior to the invasion. And so among this group, you can see that Ukrainians, immediately after the invasion, their exit rate from unemployment increases quite dramatically and throughout this entire period. So they're leaving unemployment much faster. And panel B shows that the earnings that they achieve in the first job after exiting unemployment are significantly lower. So this is an indication that their sort of reservation wages are decreasing. Okay. So we have shown this consistent effect, a negative mental health shock that's persistent. We're also seeing that they're working more, earning more. How sustainable is this? So one way to tackle this question is to look at burnout. So this is a condition of extreme fatigue caused by work-related stress. It's a relatively common phenomenon in labor markets, and it's a relatively common diagnosis in Sweden. And what we see in the data is a 25% increase in specialist treatment care for burnout among Ukrainians relative to other origins. So this is an indication of possible long-term scarring effects of burning the candle at both ends, so to speak. We run 2 external validity exercises using survey data. So in panel A here, we're using the European Social Survey, with just a repeated cross-section. We try to construct it as in a very similar way to our main sample. And what we see is that Ukrainians across Europe report substantially lower mental health after the invasion. So in 2024, it's about half a standard deviation lower than other people from other origins. Panel B, we switched to the ACS in the US. And we find that Ukrainians in the US also report much higher annual earnings following the invasion. So these are sort of strikingly consistent with the results that we find for Sweden. Okay, so in terms of the mechanism, we argue that direct conflict exposure of family can be an explanatory factor. So what I'm showing you here is a map of conflict intensity across different regions of Ukraine early on in the war. And what you can see is in the border regions is where you have most of the activity, and in western and central regions, they essentially have close to 0 conflict fatalities, even up to today. So using data on where people are from within Ukraine, we just split the sample by whether or not you're from a more or less conflict ridden area. I'm going to show you the main results here. So in panel A, the blue line represents high fatality areas, and the red line represents low fatality areas. And for mental health prescriptions, the effects are kind of very consistent. They're very similar, actually, regardless of exactly where you're from, which we take as an indication of this mental health shock being more of at a national level, a shock to the national identity, more than just the exposure of your own family and friends. Whereas in panel B, looking at earnings, they are much more clearly driven by individuals from high conflict areas. So that's the blue line, which we think is indicating that, this labor market response is driven by a need to help out family and friends who are living in these areas of origin that you're from. Okay, I have just 1 minute. Unfortunately, I have the ugliest graph or table at the end. Here I'm showing you an interaction between being Ukrainian in each year, and here number of refugees coming from Ukraine to your municipality where you're living in Sweden. And essentially the finding here is that individuals who are more likely to interact with Ukrainian refugees, so that's this table here, this column here, have less of a mental health response. So seemingly some sort of contact with other refugees that dampens this negative mental health effect, but it doesn't really have an effect on income. So let me just conclude by saying that Russia's full-scale invasion of Ukraine had immediate and long-term consequences on Ukrainian expatriates. We're likely underestimating the mental health impact because not everybody goes to seek treatment. And we conclude that violent conflicts may have public health and labor market consequences in other countries far from conflict. Thank you.
Thank you, Munir. And as we load Hitoshi's slides, let me just remind you, you can engage more with this work with Munir in the back corner of the room during the break. Next, we're very happy to have Hitoshi Shigeoka.
All right. Thank you so much for having us on the program. So this is a joint work with Toshi Izuka and also Junya Kamura, both from University of Tokyo. So the title of the paper is The Two Inefficiency of the Self-Selections, Evidence from the Healthcare. So in most settings, whether you actually seek the medical care or not is actually usually up to individual choice. So there's a self-selections. And this kind of self-selection can create two types of inefficiencies. One we call the excessive participation. So basically low benefit to individual use care anyway. So this is just a classic moral hazard kind of concern. And second is the insufficient participation. So high benefit stay away from care. Maybe they actually underestimate the value of the preventions. So then in this paper, we kind of propose a framework to detect and also address both type of inefficiencies. And the key kind of innovation of this paper is to jointly consider the heterogeneity in the selections, so basically who actually respond to the nudge, and also heterogeneity in the treatment effect, so who benefit. Okay, so our setting is Japan's annual mandatory health screening, so basically all the employer have to take it. Okay, it's something like this. Okay, so our setting is a diabetes care, and the individuals whose fasting blood sugar is 126 or above actually get nudged twice. First, all the people actually, after 1 month, all the people receive this kind of report card, and this FBS equal or above 126 is actually the common threshold to actually recommend the physician visit. And after 6 months, those who are above FBS, equal above 126, also receive this kind of reminder, basically saying that you should, see a doctor immediately. Okay, so the key kind of institutional feature is that nudges actually go to the patients, not to the physicians. So that's why there's some kind of self-selection for the physician visit. Okay, so we have actually 4 findings. First, nudge works on average in the sense that there's more care and better health. Second, however, if you look at heterogeneity, those who actually respond to the nudges actually are kind of more like healthier, and also that's why they actually benefit less from the care. So there's a reverse selection gains. Okay, and the third, because of this, targeting nudges based on the predicted net benefit actually improve welfare by reducing such kind of excessive participation. And then finally, we actually go beyond the compliance. And then, people who are actually most reluctant to seek care actually would benefit most from the care, which kind of suggests that outreach to them reduce insufficient participation and also could also further improve the welfare. Okay, so our setting is kind of obvious. It's a regression discontinuity kind of design, and then basically those who are above 126 receive this kind of nudges, both report card warning and also reminders. And we can actually observe physician visit from the claim data, and we can actually observe their health outcomes in the next year's screening. Okay, so our data is admin data, which coming from the Japan's largest insurer, which covers 40 million per year. So I don't know how many people actually know our population. It's 120. So we actually cover 1 out of 3 Japanese in this data. And we actually link medical claim data with biomarker coming from the annual screening and also health behavior from the survey. Okay. So the first result, we actually show some kind of average effect. And as you can see, like, here we have kind of bunch of jumps, So you can see on the left, probability of any kind of, diabetes-related visit within 1 year, jumps by 8.8 percentage point at the cutoff, which is basically roughly correspond to 27% of the mean. And you can see like a health outcome also improved. So here I flip the sign so that the positive number indicate the improvement in the health. And you can see that fasting blood sugar improved. And also we see similar kind of gain for other biomarkers such as cholesterol, blood pressure, and also BMI. So on average, NASH actually works. So more care and better health. However, we can actually also look at heterogeneity, and we ask who actually respond to the NASHs and also who actually benefit. Okay, here we actually use the causal estimate, causal forest to estimate the individual level treatment effect, or you call CATE, for both utilization and also health outcome. And there are two takeaways. First, NASH effect actually pretty heterogeneous, and also NASH effect actually mostly positive for both healthcare utilization and also health outcomes. Okay, then we can actually divide the people into quartiles of the treatment effect, and then see, look at their average, baseline characteristic at the index screening, okay? And here, the lighter color indicate the better health or the better lifestyle, okay? And as you can see on the left, those who actually likely to respond to the NASHs and seek for the medical care are systematically healthier, because as you can see, the Q4, which is the top quartile, are pretty much yellow. By contrast, those who actually, on the right, you see that Q4 actually pretty dark, okay, which suggests that those whose health would benefit most from seeking care are systematically sicker. So those who actually respond to the NASH and also who actually benefit from NASH are quite different. Okay, all right. So then we can actually put this in one figure, and on the x-axis we take the NASH effect on the utilizations, and then y-axis we actually take the health gain from the visit. And then you can see that this slope is completely, pretty much negative, suggesting that those most likely to respond to the NASH are least likely to actually benefit from the care. So this is reverse selection gain, or yeah. So there could be some possibility of excessive participation, and also there could be some scope for the targeting. Then we actually kind of ask, can this kind of targeting fix the issues? Here, one underlying assumption is that the policy maker can only change GI who actually get NASH, but we cannot really control. We cannot really control who actually going to seek care. Okay, so since we actually want to monetize benefit and also cost, here we focus on the reduction in the 6-year mortality multiplied by the value of statistical life to actually construct benefit, and also cost is actually 6-year kind of medical spending. And we're actually going to estimate the CATE, individual treatment effect for both beta benefit and also cost separately. And then once you have that, you can actually calculate individual level net benefit. Okay, so our status quo is that we're actually just going to nudge those over 126, and we're actually going to think about 2 ways to actually nudge fewer people to actually kind of screen the most kind of valuable people. And then the first approach is benefit-based targeting, which simply use this kind of net benefit coming from the CATE. Okay, and the second approach is that risk-based targeting, which just simply use conventional risk standard, so the conventional clinical standard for blood pressure and also cholesterol. And the basic finding is that this benefit-based targeting work pretty well. So it's kind of by construction. So the best scenario is that we're gonna just only target and send the nudges to those whose net benefit is positive. By construction, it's going to make things better, but you can see that the net benefit per person kind of triple compared to the status quo. And also, a much simpler kind of implementable kind of policy within a policy tree is going to gain welfare by 60 to 90%. By contrast, this kind of risk-based targeting actually makes things even worse sometimes, which kind of suggests that the clinical risk may be noisy signal for predicting net benefit from the NASH. So the basic principle is that we should actually target based on the benefit instead of the risk. Finally, I'm actually going beyond compliance. So far, we only focus on only compliers and also excessive participation margin. However, second inefficiency concerns those who do not respond to this kind of nudge, which we call the insufficient participations. So the question is, do they actually gain more or less? To answer these questions, we are going to estimate the marginal treatment effect, which incorporate, which actually goes beyond compliers and also incorporate unobserved, heterogeneity, where we use this kind of cutoff, as a binary instrument. And this is the MTE curve for the, fasting blood sugar. And on the x-axis, we take the unobserved resistance to seek care. And you can see that this slope is again positive, which suggests that the more reluctant you are to seek care, the more you would actually benefit from receiving the care, which kind of suggests again the reverse selection gains, even including this kind of unobservable. And then finally, once you have this MTE, you can actually calculate a bunch of objects. And here you can show that average treatment effect on untreated is larger than the local average treatment effect, which kind of suggests that there could be money left on the table in the sense that, because these ATU actually include the effect for the bunch of the never takers, which kind of suggests that, these kind of nudges misses exactly those whose actually the return is actually highest. Okay, of course, whether this kind of stronger outreach is going to pass, cost-benefit kind of test needs this kind of two kind of parameters. One is, policy cost, and the other one is the policy-relevant treatment effect, and this is actually still work in progress. To conclude, okay, so NASH, basically works. So we actually show that, more visit and better health, and we show that reverse selection gains, both among the compliers from GATE and also beyond the complier from MTE. And the targeting on the predicted net benefit actually beats conventional risk factors. And finally, outreach beyond compliers may, increase, welfare further, because those who are actually very reluctant to have those who are reluctant to seek care have the highest returns. Okay? Yeah, that's it. Thank you.
Thank you, Hitoshi. And as we load Edward's slides, let me just remind you, you are invited to engage with Hitoshi in this work in the break. He will be in the bull ring during the break. Very happy to have Edward Kong.
Hi, everyone. Super excited to be here. I'm really excited to present joint work with Yunnan Ji and Maya Roy, who's in the audience, titled Dying Better, Hospice Care and the End of Life. So end-of-life care in the United States represents a major fiscal challenge. So 25% of all Medicare spending occurs in the last year of life. This amounts to $250 billion per year, which is more than the budgets of SNAP, TANF, and SSI combined. And this high spending is driven by aggressive treatments. So in the last 30 days of life, 50% of patients become hospitalized and 25% spend time in an ICU. And this is despite patients' stated wishes to remain at home for the most part. And hospice offers a less aggressive and lower cost alternative to this that shifts care away from curative treatment, emphasizing comfort, palliative care, as well as family support. And hospice has rapidly expanded, but large-scale evidence remains limited, of course, outside of great work by people in this room. So this graph shows the increase in hospice use over time. The y-axis is the share of deaths that occur with hospice in Medicare, and this has risen from less than 20% in 1999 to now over 50%. And so the question we aim to address in this paper is how does hospice affect end-of-life care spending as well as patient well-being? Just for some background, hospice in the United States consists of services that are mostly provided in the patient's place of residence, whether that's assisted living or nursing home or at their home. It includes palliative medical care, symptom management, psychosocial support, medications, equipment, grief counseling, as well as 24/7 on-call support. The image on the left shows an example of care being provided at the home. Eligibility depends on physicians certifying that the patient has a terminal illness with no more than 6 months of life expectancy left, and the patient is required to forego curative treatment for that terminal condition. And financing is mostly provided by Medicare, which pays a fixed per diem of about $200 every day for these services. The data we'll use in this paper come from Medicare claims, and which people are familiar with, and also clinical assessments, which come from this minimum data set for all nursing home residents. And this is especially rich data for us because it involves nurses assessing patients at least quarterly and generating these well-being measures that are unavailable in traditional claims data. And for our setting, it covers 40% of all hospice patients. Here's an example of one of the assessment measures for physical functioning. So specifically, how well a nursing home resident is moving around in their bed or able to transfer from their bed to a chair and do these types of functioning activities. And this is all rated on a scale by a provider. In addition, there are psychosocial measures such as measures of mood, anxiety, and cognition, as well as detailed measures on the types of services that patients are using in the nursing home, such as the minutes of swallowing therapy that they receive, for example. The identification for this paper comes from hospice agency entries at the county level. So here's a map that shows for each county the change in hospice agencies per 1,000 beneficiaries from 1999 to 2019. In 1999, there were only about 2,000 hospice agencies, and this has risen to now over 5,000 by 2019. And our approach is going to be a familiar stacked difference in difference with matched controls, where our treatment events represent 1,500 county quarters that have a new hospice facility enter. And for each of these treated counties, we'll draw two controls that are just matched on pre-period beneficiary counts and growth, just so we're matching counties of similar size. And then we call these experiments, and then we require that each of these experiments has at least 1 year where we can see a pre-period and then 5 years where we can see what happens after a hospice agency enters. Okay, so what happens when a hospice agency enters the county? This is our first stage. You can see the coefficients to the left are flat and not significant, which is reassuring. And then after the agency enters in the dashed vertical line, we see a rapid rise in the amount of hospice spending. And this amounts to about $4.26 per beneficiary per quarter. And to put that in perspective, that's about 7.1% of the baseline hospice use in the county. We also find that hospice entry decreases non-hospice spending. And this event study shows you non-hospice and also non-drug spending decreasing by $9 per beneficiary quarter. And this is driven by a composition of both inpatient, so reduced hospitalizations, and also reduced nursing home spending. These reductions in non-hospice spending are going to vary quite a bit by specific chronic condition. So overall, for every $1 of hospice spending additional, there is an offset of negative $2.22 shown in the point there. And then across these rows, we see that there's quite a bit of heterogeneity, where for things like Alzheimer's and related dementias, it's basically a one-to-one offset, basically a wash, whereas for things like chronic obstructive pulmonary disease and heart failure and heart disease, there's way bigger spending reductions for those conditions. We also find that hospice does not seem to increase mortality in our sample, and we were able to rule out mortality increases of over 0.003 percentage points, about 0.24% of baseline, or as an elasticity with respect to the increase in hospice use, an elasticity of greater than 0.034. So even though we don't find increases in mortality, we do find significant shifts in where patients are spending their end of life. So the y-axis here shows the death share elasticity. So that's the change, the percent change in the place of death over the percent change in hospice use. And the blue bars are showing for every 1% increase in hospice use, negative 0.2 or more percent decreases in deaths occurring in institutions, in particular hospitals and especially skilled nursing facilities. This is offset by an increase in deaths occurring at home, especially an increase in deaths at home with hospice, and actually a reduction in deaths at home that are occurring without hospice services. We also see in the nursing home sample reduced high-intensity interventions among nursing home residents. So these are feeding tubes, catheters, and physical restraints such as trunk restraints, and these are all significantly declining. At the same time, we don't actually detect any effects on pain, depression, anxiety, physical functioning, or these other clinical outcomes that we're able to measure in the data. At the same time, we see an offsetting effect where there are more services that are directed towards comfort measures. So here are two of the biggest effects that we find, which is one on speech therapy, which is actually swallowing therapy, and this is the minutes of therapy provided that increases by 2.7% from baseline, as well as hypnotic use, and these are drugs that are used to help residents sleep, as well as can help with agitation as well. And we view these as potentially substitutes for the fewer feeding tubes and also fewer physical restraints that are being used. So across conditions, it seems like hospice is shifting treatment towards comfort without too much variation across conditions, in contrast to the spending results. So the conditions here are shown in the rows, so Alzheimer's and various other conditions, and the various measures of intensive interventions or comfort interventions are shown on the x-axis. And basically you can see that the colors are uniform vertically, which means there's not much heterogeneity across conditions. Okay, so in conclusion, we find that hospice reduces healthcare spending and improves patient well-being, with $2 saved for every $1 spent on hospice. We see more deaths occurring at home and more comfort-focused services with fewer hospitalizations, fewer high-intensity interventions. And importantly, we don't find evidence of adverse effects across a wide range of outcomes, including mortality and other clinical outcomes. This all suggests that on the margin, increasing hospice use could lower spending as well as improve patient welfare. And in the paper, we will introduce a model. We introduce a model of hospice referrals as a function of patient severity or underlying mortality, financial incentives, as well as access constraints. And the model shows that removing access barriers can improve welfare and also save Medicare very upper limit of $50 billion per year. With that, thank you all for your time.
Thank you to Edward for a great presentation and for getting us back on time. I invite you to engage with Edward up here in this corner after Brandon's presentation, which we are loading now. Very happy to have Brandon Churchill.
Thank you. Well, thank you to the organizers for including us on the program. I'm Brandon Churchill. I'm an assistant professor in the School of Public Affairs at American University. This is joint work with Georgina Cisneros, who is a PhD student of ours, and then Kelly Marquardt, who's at the Chicago Fed. And because Kelly's at the Chicago Fed, I will say the views here are not those of the Chicago Fed or the Federal Reserve System. Policy reform takes time. Major pieces of legislation are normally passed several years before they are fully implemented. And during this period, firms have to make strategic decisions about how they are going to respond to this legislation. And we have evidence that this uncertainty matters from fiscal policy, monetary policy, and other things. Healthcare reform is no different. So the Medicare Modernization Act, which is what I will be talking about today, was passed in late 2003, went into effect in 2006 fully. The Affordable Care Act, passed in 2010. Exchanges and Medicaid expansion come 2014 and subsequently thereafter. And then the Inflation Reduction Act of 2022, where the first negotiated drug prices just went into effect this year. So what we want to note is that how healthcare providers respond to this uncertainty determines whether the intended beneficiaries are going to be able to access care. So I'm going to be talking about retail pharmacies and Medicare Part D. So if you don't know, retail pharmacies fill 4 billion prescriptions every year. They are the most frequent service delivery touchpoint of the healthcare system. Pharmacists are among the most trusted members of the healthcare community. And over the last several decades, we've seen a rise in the importance of pharmacies through scope of practice expansions for things such as, maybe most famously, the ability for a pharmacist to prescribe and administer a vaccine, asthma medication, diabetes medication, and medication for substance use disorders. So very briefly, Part D provides prescription drug coverage to elderly individuals, as I said, passed in December 2003, fully implemented in 2006. And the big source of uncertainty here was it was the first time that a Medicare program was to be fully administered by private insurers who had the ability to negotiate drug prices. So what I want to note is the effect on profit from a retail pharmacy's perspective is ambiguous. There was an increase in utilization, about a 5 to 10% increase in utilization, but there's no clear effect on price, at least ex ante. There is a greater willingness to pay among these newly insured, maybe elderly individuals. That will push up price. But now we have insurers serving as this intermediary with increased negotiating power, with the ability to maybe push down prices. It's also possible that costs could, if average total cost is increasing in quantity, or potentially shifts in response to greater administrative burden, you could wind up with a sufficiently large quantity increase that would push costs above any price. So in the paper, we work through a theoretical framework where we think of a high elderly share and a low elderly share market, where each market has one pharmacy and one potential entrant. The entrant is going to pay a fixed irrevocable sunk cost. And Part D is going to generate some uncertainty about what profitability is going to look like once it's fully up and running. And what I'm going to show you is that the key for us is that the upside and the downside risk are both going to be greater in areas where Medicare beneficiaries comprise a greater share of the customer base. So from the potential entrance perspective, when they're looking at this saying, I don't know what's going to happen next year or 2 years from now, we're going to show the value to waiting for full implementation is going to be greater in those areas where there are more elderly individuals relative to fewer elderly individuals. So from this framework, we get a couple of testable predictions. One is that new pharmacy openings will fall between passage and implementation in high elderly share areas relative to low elderly share areas. If there is any rebound, is going to depend what is the realized state post-implementation. Are we going to be in that higher profitability state or lower profitability state? So drawing on the literature on drug prices and administrative costs, we think that it's going to suggest that there won't be a rebound, but we acknowledge it could happen. And any change in exits will be smaller in magnitude and will occur after implementation here. So we test these in a couple different data sets, establishment level data sets, the National Establishment Time Series data, and the county business patterns. Broadly, we're going to be thinking of the number of retail pharmacies in a county. When we have the NETS data, we're going to be looking at openings and closures as well. We have information on sales, employees. And we are going to do this in a county level diff and diff, where we are going to be comparing changes in counties with an above median share of elderly individuals in the year 2000 to the concurrent changes in those below median counties. So I'm going to do it above and below median here. In the paper, we do it continuously. We do it in quartiles. Above and below median is just going to make the event study a lot easier on the next graph. We will include some county level demographic information, county fixed effects, and then state by year fixed effects to absorb any other big policy variation at the time. Okay, so consistent with our one of the predictions of our model, we see no evidence of a differential pre-trend, and then during that initial uncertainty window, we start to see a reduction in the number of pharmacies. So within the NETS data, it's about a 6% reduction. County business patterns, it's 4 to 7%. That does not rebound post full implementation. We see larger reductions in lower income counties relative to higher income counties. Part of the reason for this, we think, is that lower income counties have more dual eligible individuals, and dual eligible individuals shifted here from Medicaid as the payer to Part D, and the Part D reimbursement rates were significantly lower than the Medicaid reimbursement rates. We see larger reductions in more racially diverse counties relative to less racially diverse counties, and larger reductions among standalone, independent, small mom and pop pharmacies relative to the non-standalone pharmacies. Part of this could be standalone independent pharmacy. About 90% of their revenue is coming from prescription drugs. At a CVS, you're thinking like 50, 60%. And those smaller pharmacies are probably less able to smooth out those costs as well. The patterns are robust to things. You should check the paper in the interest of time. So when we look at openings and closures, we see a reduction. This is driven by a reduction in the number of openings. We don't see anything on closures. This is consistent with the prediction of our theoretical framework. And that reduction in the number of openings occurred when it was particularly uncertain about what would happen when Part D was implemented. We don't see any rebound once it was fully implemented, which suggests to us the realized state of the world was the lower profitability state. Okay, so it's a health meeting. We said, what about health? So for this, we build on work by Jason and Julian, which did a diff and diff comparing mortality for 66-year-olds to 64-year-olds around the time of Part D, where they find about a 2% reduction. So first off, we replicate it. It's easy to replicate things when Julian posts all his code, so thank you, Julian. With a little bit different of a time period, we also see about a 2% reduction. But then when we split it up and look at the low and high elderly share counties, we see those mortality benefits accrued in those areas that were not the ones that saw a reduction in the number of pharmacies relative to the counterfactual. When we put this into a triple difference framework specification, it's not statistically significant, but we think that this is suggestive evidence that the mortality benefits or the mortality reduction attributable to Part D was smaller in those counties that also experienced a reduction in the number of pharmacies relative to the counterfactual. So in conclusion, we found about a 5% reduction, evidence that it may have increased disparities in poorer counties, racial and ethnic minority communities, possibly attenuated the mortality benefits from Part D. One limitation I do want to notice, we don't have data here on reimbursement rates or administrative costs, so I can't say which one of these is driving. That's probably, you want to really think about that for the policy implications, but look forward to your comments. Thank you all so much.
Thank you, Brandon. Okay, as a reminder, in this 30 Back on time. Hope you had a nice long break and got a chance to talk with the egg timers. Great. Thank you so much. We are very happy to have Anna Russo here from Harvard. Anna, you have 5 minutes completely uninterrupted.
Okay, amazing. Thank you so much to the organizers for putting together a wonderful program and for including this paper. I'm going to be talking about waiting or paying for healthcare at the VA. So to start, healthcare is frequently allocated without or at below market clearing prices. And this is often done in many settings in the interest of fairness or distributional concerns. If we look across the founding documents of many healthcare systems worldwide, many include explicit limits on the use of prices in order to ensure that no one forgoes access to needed healthcare regardless of their ability to pay. But at the same time, in many of these systems, kind of capacity or budget constraints often bind, necessitating alternative ways to allocate this scarce capacity. And what we frequently observe in many of these settings are endogenously arising wait times to see a doctor. And indeed, wait times, as opposed to prices, are cited as a key barrier to accessing care in most OECD countries and as a frequent motivator for health policy. And even more broadly, zooming way out, this observation that wait times are high in some healthcare settings and prices are higher in others often comes up in high-level debates about kind of healthcare system design. Right, and what we'll try to think about in this paper is the fact that waiting on the one hand and paying on the other hand are going to be two distinct allocation mechanisms that will have distinct efficiency and distributional consequences, both of which will ultimately be empirical questions that will be useful to understand either the effects of or motivation for policy designed to address high wait times or these kind of higher level comparisons. And so we're going to do so in the context of the VA, or kind of I'll abbreviate it as both VA and VHA, which is the largest integrated healthcare system in the US. So as an overview, our setting will be outpatient care at the VA, which has the distinct advantage of having patients choose options that are going to vary in both their wait times and their prices. This is because the VA, like many other healthcare systems, features low regulated prices, and the market instead clears on wait times. Because wait times are a concern at the VA, there was a policy passed in 2014 called the Choice Act that will be a focus of this paper. And it essentially attempted to address congestion or wait times inside of the VA by subsidizing the kind of outside non-VA healthcare option for certain eligible veterans. We're going to first analyze this Choice Act policy in two difference in difference designs. First, what I'll call the direct effects, comparing eligible to ineligible veterans and analyzing the effects of this Choice Act policy, which I'll kind of argue we can interpret as a reduction in prices on veteran choices. And then second, using an additional source of variation introduced by this policy, analyze its equilibrium effects and show that it affects wait times. Right, so this is both kind of an informative evaluation of this important Choice Act policy and also kind of useful because it's going to be shifting around both prices and wait times. And we'll use this to show some initial patterns of heterogeneity in response to these choices, which is going to be informative of their different allocative effects. Then finally, we'll embed this same policy variation in a very simple model of clinic choices for primary care, right, which we'll use to kind of quantify the joint distribution of willingness to wait at zero prices and willingness to pay at zero wait times, and any potential combination in between. And we'll use this first for a quantification exercise, returning to the question that I posed on the previous slide, comparing the status quo in which prices are low but the VA is congested to this hypothetical alternative in which we reduced congestion to zero by kind of solving for market clearing prices. And we'll find with this comparison that waiting leads to a substantial redistribution of surplus, largely to lower socioeconomic status veterans, but at kind of a very high efficiency cost. And I'll explain later in the talk like how we can think about this as high or low. Then we'll kind of come back down to earth in the VA policy environment and kind of consider this Choice Act policy that the VA passed as a tool to addressing the inefficiency of the congested status quo. We'll find that despite the fact that the status quo is quite congested and inefficient, right, the Choice Act policy actually reduces social welfare on net. And I'll argue that it's because it's targeting kind of not directly targeting the source of the inefficiency. An alternative of a targeted copayment increase does target this inefficiency directly and substantially outperforms this Choice Act policy and uses targeting to mitigate adverse distributional consequences. Great. Okay, so the VA setting is what we're going to study. It's the largest integrated healthcare system in the US. Sydney talked about the VA yesterday, so she did me a great service. I'm going to be focusing on outpatient care at the VA, which is delivered throughout the VA at its network of kind of over 1,000 hospitals and outpatient clinics, and it is mostly free for veterans. About 1/4 of veterans do pay some positive copayment. This is a function of what's called their priority group, which is dependent on their income, their service-connected disability status, among others. These copayments are quite low, $15 for primary care, $50 for specialty care. At the same time, kind of access to care is a huge policy issue at the VA, in large part because of concerns about wait times, right? And this has been a major policy issue for more than 2 decades. We're going to use data from the electronic health records from these VA clinics and hospitals, as well as enrollment and cost information from 2011 to 2017. This has the distinct advantage of being able to observe, in an albeit imperfect way, but observe wait times, right? Despite the fact that wait times are an important issue in many healthcare domains, they're really challenging to observe. This is because the VA electronic health record system integrates with the scheduling system of the VA, so we can measure wait times as the time between somebody calling in and requesting an appointment and the date that that appointment was scheduled to occur, right, and aggregating up to the clinic by time level to construct a measure of congestion or wait times facing each individual patient. Then, for about 1/3 of the population who are dually eligible for both the VA and traditional Medicare, we will link this VA utilization information to their Medicare claims. This is going to be useful because it's going to mean that for this subpopulation, we're going to be able to observe all of the choices that they're making inside and outside of the VA. And I want to flag that kind of when possible, I'm going to try to analyze things as broadly as we can, but it'll often be necessary to zoom in both to this Medicare dually eligible population, which has the distinct kind of data completeness advantage, and also kind of, and this is particularly true for this choice model that I'll talk about later in the talk, kind of to a homogeneous market, and that's going to be kind of primary care, an important kind of mode of care delivered by the VA in a setting where wait times are both kind of important at the VA and also relatively well studied and validated. Great, yes, question?
Just curious, given that they care a lot of wait times, are there any incentives on providers to clear the queues faster?
So, not directly. So this is a great transition to the Choice Act policy. So historically, the providers were not so much incentivized to clear, they were incentivized to clear the queues faster. And so this led to measurement problems wherein people were not being kind of placed on queues or the measured wait times were being endogenously manipulated. This was in fact like part of a very large scandal that led up to this Choice Act policy. And so they have since kind of put way less emphasis on kind of any sort of policy response that is directly like related to or in response to wait times. Great, okay, so this Choice Act policy, it was passed in 2014 in response to kind of both a large scandal about measurement of wait times and also kind of concerns that veterans were waiting too long to receive care. And what it did was it subsidized the outside option of kind of community care, this is VA parlance for non-VA healthcare providers, for certain eligible providers, for certain eligible veterans. And so essentially, kind of what it did is it reduced or equalized the price that a veteran would pay, both inside the VA and outside the VA, but by bringing the outside the VA price down to their VA copayment. So if I, for example, face kind of a 20% coinsurance rate outside of the VA, but I'm a veteran that pays $0 inside of the VA, then if I'm eligible for the Choice Act, I pay kind of zero across the board. So it's a choice act in the sense that you have the choice to choose to go to whatever provider you want without a price differential. Right? I'm emphasizing this price point, not only because we're going to study in large part this Medicare dually eligible population in which this is true, but also more broadly about 80% of veterans at the VA have another source of insurance coverage. Providers are going to be paid Medicare rates. Only certain veterans are eligible for this Choice Act policy. They're eligible if they live more than 40 miles from their closest VA primary care site or in one of 3 states, or if they have to wait for an appointment based on a specific VA definition that is quite manipulatable for over 30 days. And I want to emphasize, I'm going to be talking about the Choice Act policy as kind of moving around prices and wait times, but it's also kind of really important to the VA and in a broader policy context. So in 2018, a policy called the Mission Act was passed. This essentially relaxed these eligibility requirements, allowing more people to receive these subsidies to go out to the community care. And there's a bill in Congress right now called the Access Act, which is further doing so. Right? And this is all representing a substantial shift from make to buy at the VA, in large part prompted by this policy. And more broadly, kind of this tool of using the kind of private sector as an escape valve for a congested public sector is a commonly used device across many healthcare systems around the world. So this policy lends itself nicely to 2 empirical strategies. So the first is what I'll call these direct effects. How do choices respond to Choice Act eligibility or this price reduction for kind of some of these health care options? And we're going to use this distance eligibility requirement because it's really particularly clean and compare those that live more than 40 miles away versus less than 40 miles away from their closest VA primary care site over time. And we can zoom in for kind of comparability in this 10-mile window around this 40-mile cutoff. Then the second dimension that we'll try to exploit is ask kind of whether wait times are affected, which we'll do by calculating differential exposure across different locations, where we'll calculate exposure as the pre-period visit share that is eligible for choice in a given location J, and examine how wait times vary in the more exposed versus less exposed locations, conditional on location and time fixed effects. And I'm being kind of intentionally vague on location because, we can of course calculate this for a number of potential J's. This could be market, this could be clinic, market by specialty, et cetera. And I'll show you a few different versions. Okay, everybody's being quiet, so we should ask questions. So first, I'm showing the, oh, great, okay, perfect. Okay.
I was going to say this later, but since you
No.
asked, later if you want. So, a lot of us teach about the VA in our undergrad classes, talk about kind of the best American example of long-run incentives to minimize care later by doing things now that the private sector where you're going to churn doesn't have those incentives. Are you going to look at kind of treatment and diagnostic differences in the private sector for veterans, or is that a different paper?
So I would say that is a different paper, or that is not in this paper. So one thing that I'll say is that, okay, so I'll say what's in scope of this paper, what's out of scope of this paper. So certainly veterans can have kind of a strong preference to get care at the VA, and the VA is going to provide a differentiated health product to the veterans themselves versus this community care. So one thing that comes up a lot, and I think is very much true, it's not exactly what you said, but I think it's really important in this setting, is for specific types of veterans, they just really like being at the VA, being with people who call them by their title, who know their experience, who have other veterans around them. That's very much captured. The extent to which either that or other care that the VA provides has long-term fiscal externalities, like onto the VA, or internalities or externalities onto the VA, is not going to be captured. And just in general, kind of, I'm also going to be not capturing kind of any kind of direct health effects or health differences across the VA or community care. There's excellent work looking at that, but it's going to be all about kind of the revealed preference choices of veterans choosing to go to one versus another, which will capture some stuff, but not others. Great, okay, amazing. So here I'm plotting the kind of coefficients from this direct effect regression. So x-axis years, y-axis is measures of utilization per veteran per year. On the left-hand side is community visits, on the right-hand side is VA visits. Right? And kind of remember, each of these coefficients is comparing kind of veterans farther from versus closer to around this 40-mile threshold. And so what we see is kind of perhaps intuitive and unsurprising for the veterans that are eligible for the Choice Act policy and see the kind of price of community care go down. They increase their utilization of said community care, kind of demand curves slope down. And the magnitude of this increase is about a 4% increase, representing the fact that these price changes are somewhat modest. Right? About half of this increase in community utilization is coming from substitution away from VA. Right? So we see substitution away from VA, but it's less large than that increase in community visits. Right? So this means kind of two things. One, this is to some extent alleviating some congestion at the VA. The Choice Act policy is getting veterans to substitute away. But also two, some of this substitution is coming from the outside option. Veterans are increasing utilization overall, and this is increasing spending for the VA on net. Yes?
Is this a price elasticity, or is this a price plus the VA helps with the process and encourages you to go to the community and works on transition and coordinated care?
Great. Okay, so I would say that, first thing that's interesting to note, read this question, is the dynamics, right? You see this increasing kind of phase in. This is very much representing kind of this combination of the price change and the challenge of getting access to community care, especially as it's being rolled out in these earlier years. By the last years of the post period that I'm showing you here, I want you to interpret it more as a price change. And this is in part that particularly for these distance eligible veterans, all of their care is potentially, like they can potentially be provided in the community. They get a card that lets them go in the community. They can really do whatever they want. For these wait time eligible veterans, it's a lot more complicated because it's like conditional on a given spell of care. It's much harder. But kind of, I think that this kind of caveat for interpretation is important because this 2024 Access Act that's kind of currently in Congress right now, the main thrust of it is essentially getting the VA to encourage more veterans to go out to the community. So there is this sense in which there's of course a role for the VA and the doctor as care coordinator to sort of influence where veterans are going. But I'll show you a number of slides from now that this price change, or interpreting through this as through the lens of a price change, leads to kind of elasticities that are pretty comparable to elasticities that we see in other outpatient settings. Yes?
Just do this. So the 40 miles seems pretty far away, no? Oftentimes we see that people care a lot about distance. I guess two questions on this. First, who is on the margin here? And second, maybe what's the baseline probability of choosing a VA that is 40 miles away? I mean, how many people will consider that? Have you thought about that?
Yes, so definitely. So the VA is unique for a number of reasons. A really important one in this context, 40 miles is really far. These veterans are quite rural.
Not in Alaska.
Yeah, exactly. Not in Alaska, but actually, but all of Alaska is eligible. So basically, veterans, particularly for the answer to the question that I was saying earlier, like this kind of intrinsic preference for the VA, veterans are willing to travel like quite far distances to go to VA. So I wish I had the number off the top of my head, but I think it's like a lot, maybe 25 to 40% of these veterans at the kind of VA, at this 40-mile threshold are going to see a VA doc. And this is in the context of the fact that only about 2/3 of enrolled veterans touch the VA in any given year for a variety of other reasons unrelated to distance. But of course, you should be thinking about this as acting in like rural healthcare markets. Okay, great. So I'm motivated with this kind of high level kind of distributional concerns motivation. And so this policy change offers kind of a nice setting to try to study its merit. So what I'm plotting here is kind of these same coefficients, now kind of zooming in to these two subpopulations that I mentioned for comparability on both. First, for primary care to ensure kind of comparability in the type of care sought. And second, for these Medicare dual eligibles to ensure comparability in the prices that they are facing. And I'm splitting the sample here by above versus below median income veterans. And so we see that these below median income veterans in blue, right, are much more responsive to the same change in price as these above median veterans in beige. And again, kind of this is perhaps not surprising at all that lower income veterans are more responsive to a given change in price. We see this kind of across many product markets, but in this particular setting, it would mean that kind of when we're thinking about these two different kind of ways to screen, that it's perhaps kind of intuitive that prices would disproportionately screen out these lower income veterans. But of course, kind of prices aren't the only thing going on here. Kind of congestion is sort of endogenously responding. Right, so we can turn to the second empirical strategy, which now I'm shifting from a veteran level regression to a location level regression, where I've scaled the magnitudes of these coefficients to represent a move from the 10th to the 90th percentile of the exposure distribution. Right, and on the left-hand side, I'm kind of defining a location at the market level across all outpatient specialties, so market by outpatient specialty. And I want to emphasize that because veterans are traveling so far for care, this is an HRR, not an HSA, because HSAs would typically have like very sparse VA clinics. And on the right-hand side, at the clinic level for primary care. And we see across both that wait times decline following the policy change, on the order of between 5 and 12 days. And so what we can take from this is first, the policy is affecting congestion, and so this is going to mean that those who are ineligible or inframarginal may be benefiting as well from reductions in wait times. And to value this, we would need to value these wait time reductions. And second, that this policy is actually shifting things around on two different kind of axes of variation. Right? There's the direct eligible comparison over time that's seeing differences in prices, and then conditional on one's own eligibility, the number of other people who are eligible in your market is going to shift around wait times. And so we can use this second dimension of variation to kind of return to a kind of a parallel exercise to that heterogeneity split on price, and look at, among those who are not directly eligible, what is their utilization or the log market share of a given demographic group D as a function of the wait time, conditional on those same location and time fixed effects. Right? And we can instrument for wait times using this variation that I was showing you on the previous slide.
Really boring question, but why are you using HRRs rather than the VA's own VISNs or their subregions, which are more relevant for these clinics?
No particular reason. I was doing it only because in the kind of main choice model, I'm going to be linking with the Medicare Medicare TM. So I was like, oh, I'll use the Medicare HRR, but really no particular reason. I could do it that way also. Okay, and so what we see is that first, this coefficient beta is negative across the board, right? Utilization responds negatively to wait times. People don't like to wait. Right? And kind of perhaps more interestingly, when we look across these demographic groups, both by the income split I was showing you before, and also to some extent by health status, where I'm kind of characterizing people as sicker or healthier based on their prior utilization, right? We see that though differences exist, their magnitude is more compressed relative to the kind of quite different responses we saw in terms of changes in utilization in response to price along these income margins. And so kind of while this is interesting and informative, and kind of I'll return to this at the end, it's kind of not exactly what you would want, which is exactly how veterans are trading off, kind of waiting one more day and paying one more dollar, right? But we can still use this source of variation to get at this. We just like kind of a little bit more of a choice model to be able to model those choices and quantify them directly. Yes.
Type
Yeah.
But, you know, the doctors involved as well, how do you think about that?
Yeah, totally. Okay, so I think this is really important, and I think it will like be okay, and like we'll make a bunch of the exercises. You can kind of hold that interpretation in your mind, and that would still be, you know, totally fine. I'm thinking about like descriptive exercises with respect to who would go where in response to higher wait times or prices. Like all we would need is that these choices are kind of accurately, like kind of our choices are kind of responding, or our model is accurately capturing choices in response to these margins, which kind of, if we think that the kind of doctor-patient decision making is held constant across counterfactuals, we're good with. When we want to do things like calculate the dead weight costs of waiting or consumer surplus, it's all going to be much hairier, and I think that that is like totally a reasonable caveat to have in mind, and I'll flag for just to be totally clear, like when we're moving in between those different worlds. Okay, awesome. So we're going to try to use, yes?
Sorry, just interpretation question. Could you walk through it on a previous slide? Like, so the income is defined at the patient level, but this regression is at the clinic level. Can you say a little bit more about what, how you should do the table?
Sorry, no, this was unclear. So I've tried to sort of separate it out to be basically like just take two different copies of the world, split it by demographic groups. So it's the market share of a given demographic group D. So it's like, suppose we took only the high income veterans, that was our world, and we're estimating demand on those high income veterans versus those low income veterans. Great. Okay, so we can write down the indirect utility for veteran I receiving primary care at clinic J in quarter T as a function of the characteristics of that clinic. Most importantly, that's going to be whether that clinic is VA or community care, and those kind of preferences could potentially evolve over time. It's going to depend on how far the veteran has to travel to a given clinic, their wait time, their out-of-pocket price, right, and two kind of unobserved demand shocks. One is common at the clinic by time level to all veterans, and the other is a type 1 extreme value preference shock. Veterans are going to be choosing whether they go get care at a VA clinic, at community care, primary care providers, or kind of an outside option of no care. Right? And this paper is all about demand. So the supply side is going to be intentionally kind of incredibly simple. We're going to assume that VA clinics are kind of strictly capacity constrained at observed utilization, which we're going to read off the data as kappa. Right, so in essence, what this is going to mean is that kind of across counterfactuals, we're going to hold the number of veterans receiving care at the VA fixed at observed levels and simply vary who is getting that care. The second assumption, which is a really important assumption, is that we're going to assume that the kind of community primary care providers are not capacity constrained, or that the veterans can sort of go out and get care at the community. Right? The kind of most important substance of this assumption is that kind of VA policy changes aren't going to have spillover effects onto the community, right? And this is kind of largely motivated by the fact that the VA is typically quite small relative to the overall healthcare market. We're going to estimate this. Question?
Does that also mean that wait time for community clinics doesn't adjust in the counterfactuals?
Yes, yes. So that's exactly this. So there could be some kind of positive wait times, like you're not just like getting into any community doctor immediately. That'll sort of get absorbed if that's constant across counterfactuals in this like community care observable. But so this is the key thing is that that can't be changing endogenously in response to the counterfactuals. And so the main assumption is like VA is small. So for estimation, we're going to use this choice act variation, kind of exactly as I was talking about in the kind of slides previously, exposure instruments for wait times, and this difference in difference variation for prices. And because we really need to see everybody's choices, we're going to use this Medicare dually eligible sample. And so this is another important caveat, which is that kind of I'm estimating it on this Medicare dual eligible sample, so these are the preferences for this specific subset of the VA population. So what I'm showing you here is a very simplified version. Yes?
How are we thinking about the measurement of wait time? Like, how should I look at patients' forecast about their wait time today? Are you just using realized wait times in that period, or?
So I'm doing it's not quite realized wait times in that period. It's basically, I'm I'm going to look at all patients who have called into a VA at a given clinic by time. And I'm going to say, I'm going to try to aggregate up those wait times, but I'm worried about taking a simple average because those might be selected, because on the days when we're not seeing wait times be recorded, that might be because they're particularly high. So I'm going to combine this kind of fact of this observation with sort of like a simple first come, first serve queuing assumption, such that on any day where I don't see a wait time recorded, I'm going to take kind of the earliest date that was recorded previously and say that that was available on that date and aggregate it up. So that's mechanically what I'm doing, right? There's a question of what do veterans know and what is the wait time that they're facing, and is there kind of heterogeneity over time within my clinic quarter level. So I think those are all kind of important, and this was sort of why I was kind of emphasizing at the beginning that we get this amazing way to measure wait times, but it's very much imperfect. So I'll give like one just little bit of institutional detail that might be somewhat helpful for interpreting. So when a veteran calls in to make an appointment at the VA, they'll talk on the phone with the scheduler. That scheduler will give them information about the wait times, kind of as many have people done when they're talking and making an appointment, both kind of at a given index clinic, but also at other clinics around. But of course, it's all subject to the aggregation.
Just, I think more specifically what I have in mind is because you show that the Choice Act takes some time to lower wait times, like I don't know how to think about in the like interim period between enactment, like when you get to the student equilibrium, what do patients believe or know about what their wait times are going to be in the future when we're still like out of equilibrium?
Yeah, so I think, so specifically, so in that case, I think, so I'm basically just using the wait times that are kind of observed in the data in that quarter, so there's no sense in which I'm kind of thinking about patients' expectations in the future. But certainly, especially for these distance eligible veterans who might be like maybe transitioning like a bunch of their care out of the community, I think there are actually like two important assumptions here that are kind of all kind of put aside in this simple model, right? The first is sort of complementarities across time. Like if I think that wait times are going to adjust in the future, and that's basically making it more valuable for me to go to the community today. And also like complementarities across like types of care being sought inside versus outside of the community, right? This is a model for primary care. It's not kind of taking into account the fact that your kind of preferences to get referred to a specialist outside versus inside might also be a function of the wait times inside the VA. Okay, so what I'm showing here is kind of a very simple kind of version of that kind of indirect utility model on the previous slide without any heterogeneity. So we only have two coefficients of interest and then their ratio, the coefficient on wait times gamma, the coefficient on price alpha, and what I'll call the cost of delay, gamma over alpha. This is exactly kind of this value that I was alluding to. How much would you be willing to pay to move an appointment one day earlier? And I have two columns here. One I've labeled OLS, the other I've labeled IV. In the OLS column, we're not instrumenting for wait times. So while we see a coefficient on price that is negative and an elasticity of about -0.3, which is reasonable with respect to other studies in the literature, right, the coefficient on wait times is kind of statistically indistinguishable from zero and actually positive. Right, this is coming from the simultaneity of supply and demand. Wait times are being kind of determined in equilibrium, and this is, of course, going to bias this coefficient upwards. When we instrument for it, it becomes negative, and we have an elasticity with respect to wait times that's about 3 times as large. And when we divide one by the other, this cost of delay, like we get an average cost of delay in this primary care population of about $2.50. Veterans are willing to pay $2.50 to move an appointment one day earlier. Yes?
Confirm in the second row, those are really exactly identical.
They're really exactly identified. Well, no, I'm just repeating that. What do you mean? What do you mean by that?
0.0079, negative 0.0079, and your IV and your OLS coefficients
are exactly identical. Identified versus identical. Yes, I think they are probably not exactly identical, but they are very, very close.
Right. So that order.
Yeah, and I think one reason for this, I need to like be 100% sure. I think one reason for this is that like because this wait time coefficient, I'm kind of explicitly I'm trying to separate these two sources of variation. So it's possible that the kind of coefficient on price is sort of, I'm kind of controlling for kind of clinic by time fixed effects such that this wait time stuff would be kind of washed out, and I'm estimating this off of the indirectly eligibles, but I will triple check. Okay, and so we have lots of observables Z that we were parameterizing these kind of preferences by. These are things like income, prior health status, age, priority groups. And so we see that kind of not only is there kind of an average cost of delay in the population, but there's substantial heterogeneity. And this heterogeneity is going to be really important because kind of this heterogeneity is going to drive kind of who gets care under what regime versus an alternative. Because all else equal, someone with a low cost of delay is going to kind of be willing to wait and prefer kind of a congested wait time regime to any alternative. And so we can think about the implications of this preference heterogeneity with kind of a stark quantification exercise. And this quantification exercise is going to compare kind of the status quo in which prices are fixed and wait times are endogenous, right, to this kind of extreme hypothetical in which we impose that wait times are 0, right, and prices are adjusted so that kind of we satisfy this market clearing condition that observed capacity or observed utilization equals kind of estimated demand at that vector of prices. And so what we find is that kind of course, in the status quo, wait times are high, prices are low, and in this alternative, in which wait times are low mechanically, right, the median copayment charged at a VA clinic would be about kind of $80. Right? This is higher than kind of the $15 charged to the 1/4 of veterans, higher than the $50 charged for specialty care. But interestingly, only about 20% of the cost of providing a VA service. And so one way of thinking about this kind of $80 number is sort of this is the kind of implicit costs that the marginal veteran is paying, right, to receive care at the VA. Yes?
Maybe this 20% is not important for interpreting your results, but you're saying a primary care visit's real economic cost is $400?
So this is based off of so Cindy was mentioning previously or yesterday that there's kind of a cost accounting method at the VA that sort of takes kind of like aggregate VA cost. Obviously there are no like VA is not fee for service, and sort of attempts to monetize it. It is not $400. It is slightly lower. Maybe this is this median copayment charge versus mean, but the VA primary care is much more expensive, or kind of marginally more, is medium level more expensive than a primary care visit under Medicare. Under this
4x sounds more than medium more expensive. Maybe their allocation of cost is crazy,
yeah.
Or maybe they are way more expensive than other ways of providing care, which would not be shocking for an agency, but that's not what people have claimed in the past.
Yeah, okay, no, this is good. I will double check this. And then because of the kind of heterogeneity that we saw on the previous slide, this is going to lead to kind of different veterans receiving care. About 16% of veterans who would have received care under the status quo regime wouldn't under this flexible pricing regime, and vice versa. Yes?
Have you thought about bringing travel costs and time costs into this?
Yeah, so they're in it very implicitly, in the sense that, I'm going to go back a bit, in the sense that there are travel costs here, in the sense that veterans are kind of more willing to go to a close clinic than an alternative one, and kind of just as I'm kind of using these two sources of variation and stitching them together to monetize the waiting costs, I could monetize these travel costs, certainly. And so what's interesting about this, I'll just say very quickly, is that veterans' like implied travel costs from this are very high, because they don't want to travel, and kind of when we divide that coefficient by the coefficient on price, it leads to very high implied travel costs. Great. Okay, and so we can think about the differences in kind of allocations across these two regimes that would be implied by this heterogeneity in choices. What I'm plotting here is the kind of change in the population composition under this status quo versus this alternative, kind of the mean characteristics at the VA in blue, and for any care in beige. And what we see in blue is that at the VA, the veterans being served under the kind of wait time regime are disproportionately lower income, sicker, and older. Right? And so this is the sense in which this wait time regime is kind of reallocating access to care to these types of veterans who are kind of disproportionately lower socioeconomic status. And what we can do is we can now move from kind of this picture, which was describing choices, to kind of a more normative interpretation where we would calculate consumer surplus to calculate winners and losers under one regime versus an alternative. And we find that actually 55% of veterans prefer, from this consumer surplus measure, the wait time regime versus this kind of flexible pricing counterfactual. But at the same time, kind of again, this is now where we're really relying on the kind of revealed preference interpretation, and so I want to kind of flag and caveat. But at the same time, kind of this wait times congested regime kind of is highly inefficient, right? Social welfare under the status quo is about 23% lower than this flexible pricing alternative. And we can decompose this reduction in social welfare into three components. The first is a reduction in allocative efficiency, which had to be negative, right? We're defining allocative efficiency by highest willingness to pay veterans receiving care at their most preferred clinic. Of course, this is not going to be true under the wait times regime. The second bar is what I'll call kind of the change in screening costs. This is for the veterans that are receiving care at the VA across counterfactuals. And what is the cost to them of kind of parting with $1 versus waiting to get that care? And so this could be positive or negative and depends on kind of the cost of delay of this marginal veteran versus the inframarginal veterans. And we find that it is negative in part because the veterans who are kind of attached to using the VA and who will go no matter what find waiting particularly costly. And then the most important component of this is the fact that revenue is not raised under the wait time regime, although costs are imposed, right? It is a dead weight loss. And so this is, again, we knew this was the case at the beginning, but we can use these choices, this model, to quantify it. And so this is a sense, and we can think about whether this reduction in social welfare is big or small, because we can redistribute this revenue lump sum among veterans. And when doing so, we find that after redistributing this revenue lump sum, only about 3% of veterans prefer status quo waiting, or any veteran's individual change in consumer surplus is small relative to the revenue that is not raised because waiting is costly. Yes?
Anthony May mentioned, I missed it, but where are the hospitals in this? I mean, basically, if they're using different levels of primary care, the big spend is the hospitals.
Yep.
They always go to the VA hospital, and does it affect whether they go to the hospital? It seems like they're missing a spending piece.
Yep, that's a great question. I don't have any of this here, but I can look at whether kind of the choice eligibles, even though choice actually only covers outpatient care, I can look at whether the choice eligibles use more or less or different types of hospital spending as a result of this and add that in, because of course this will swamp outpatient spending. Great, thank you. Okay, so of course this was kind of a thought exercise or a quantification, not kind of any sort of realistic set of policy counterfactuals, but we can kind of come back down to earth of the VA policy. This congestion and wait times is very costly, and so in some sense, having the Choice Act policy as a tool to address it may be smart. So we can use our estimates to calculate kind of the gains from this Choice Act policy, first calculating the change in consumer surplus, summing it up with the change in revenue net of costs to get kind of aggregate social welfare. Under the status quo Choice Act in column 1, right, the expansion to the Mission Act eligibility requirements in column 2, and then in column 3, expanding this to everyone. And so what we find is that of course the Choice Act policy increases social welfare, right, but it does so less than the increase in costs. Right? And so kind of one way of interpreting this is that kind of the source of the inefficiency, and again, this is subject to the revealed preference interpretation, but the source of the inefficiency isn't underutilization per se, but the kind of wait times that people are bearing that are causing costs at the VA. Right? And so because of this, the Choice Act policy, which is sort of only indirectly affecting wait times through this substitution of people going away from the VA, right, and is increasing kind of utilization overall, right, is only addressing this inefficiency indirectly, and in doing so is kind of increasing spending, and this is kind of, again, interpreted through the lens of the choice model and kind of the cost data at the VA, increasing moral hazard spending. Right? Addressing the source of the inefficiency directly, right, we could think of doing so in a more kind of realistic policy scenario, which what I have here in column 4. What I'm doing here is I'm increasing the copayment that veterans that already pay copayments pay from $15 to $50. This is undoing a policy change that occurred in the early 2000s at the VA that reduced copayments from $50 to $15. So it's undoing it. Right? And these targeted copayments for those veterans who already pay copayments are disproportionately kind of higher income and non-service connected disabled veterans. So what we see is that despite the fact that veterans are now paying more, consumer surplus goes up a lot, by much more than under any of these Choice Act policies, because this targeted copayment is being levied on the congested VA directly, and so is affecting congestion much more directly. And of course, kind of this also has, again, a positive effect on revenue instead of a negative effect on costs, but this, in terms of the consumer surplus calculation, is swamped, or it's much more important that this is much more effectively reducing congestion and increasing consumer surplus. Yes.
When measuring consumer surplus, I often think of moral hazard and risk aversion as important things to think about. And how are you thinking about risk aversion here?
So, short answer, not thinking about risk aversion. I have risk neutral consumers. That's not here at all. I mean, I think it's really interesting. I mean, you can think about like the standard kind of insurance risk protection versus moral hazard trade-off acting kind of on the margin of price or on the margin of wait times, and kind of who is thinking about that trade-off differentially. Super interesting, totally not in here at all because there's no risk aversion in this risk neutral setting.
So just a little cautious then about claiming this as social welfare, right? Because this could really harm people if they are.
Point taken.
You should take a minute to conclude.
Okay, great. I'll talk with you after. Okay, so just to conclude very briefly, we studied the fact that healthcare is often allocated with wait times at low prices in the context of the VA and the Choice Act policy. And we investigated empirically kind of the redistribution of surplus that this causes at quite a large efficiency cost. Right? And the policy implication is that the Choice Act policy is the wrong tool, and that a small copayment increase substantially outperforms on the objectives that the VA cares about and can be targeted using observables. Or much more broadly, that targeted pricing kind of substantially outperforms restrictions on price when we have this endogenously arising congestive force. Thanks so much.
Thank you, Anna, for a great talk. We are now at lunch, which is down the hall. I invite You have 5 minutes completely uninterrupted.
Okay, well, thank you so much. Thank you, everybody, for being here. It really means a lot to me to be presenting here at NBER Summer, so thank you all for sticking around till the end, and thank you to the organizers for having our paper. My name is Nick Tillipman at Johns Hopkins. This is joint with Anran Lee at Minnesota, Tong Liu at MIT, and Tony Lasasso at Madison. And this paper is about intermediation in health insurance. And specifically, we're going to be looking at skilled experts. Now, these kinds of experts exist in all kinds of markets, helping to facilitate transactions between buyers and sellers. So think financial brokers who handle your pension portfolios, think about real estate agents who are trying to buy and sell your house, and think about insurance brokers, which is going to be the focus of this paper today. Does anybody here moonlight as an insurance broker by any chance? Good. Okay. One thing that unites a lot of these intermediaries is that they have drawn a lot of regulatory scrutiny recently, in no small part because they get paid based on commissions. And so this generates a lot of the agency issues that we economists like to study so much. And because of this, over the last decade, this has resulted in a lot of legislation specifically designed to tackle these sorts of agency problems. So you have fiduciary duty in finance, which I'm sure all of you have heard of. You have recent NAR settlements dictating how real estate agents split commissions. And there's been some recent blockbuster ProPublica reporting and the sort about broker kickbacks and Medicare Advantage and stuff like this, which has led to more aggressive calls from the Center for Medicare and Medicaid Services to regulate how brokers are being paid, and specifically to more aggressively cap commissions. It should be noted that this is really not that new. States have experimented with this before. New York State, for instance, capped HMO commissions before 2010, and then it relaxed it afterwards. All of this is to say, we are going to be looking at the role that brokers play in insurance markets, but we are not going to be looking at it in Medicare Advantage in this paper. We're going to be looking at it in the employer-sponsored insurance market. Now, there are several reasons why we think that this market is particularly interesting for this. One is that it is very, very big. Most people in the United States get their insurance from an employer. What we're going to show you is that most employers retain the services of a third-party broker to help them design their health insurance benefits. So it's a very big market where these intermediaries play a huge role. The other thing that we find fascinating about this is, unlike their analogs in Medicare Advantage and in ACA, for instance, the ESI market for brokers is actually far less regulated. So it's kind of the Wild West out there. And for us, we were just sort of interested in knowing what brokers were actually doing in this market. So we're going to tell you a lot about that. Specifically, what we're going to be asking in this paper is, how do brokers affect employer choice of health plans and insurer competition, and whether there is room for regulating commissions given what we find on these effects. On the economics, we're going to be focused on two primary mechanisms, two potential distortions that we think brokers might inject into the market. The first is a sort of standard commission-driven steering distortion. So because brokers are paid by commissions, they might direct employers to plans that they might not otherwise choose. The other is what we're going to be calling an anti-competitive distortion. And this is going to arise out of the fact that it turns out that brokers form contracts with upstream insurers, and that brokers do not need to have complete contracts in this market. So if I'm a broker in New York, I do not need to be licensed to sell every single carrier. So much like insurer-provider networks, there's going to be networks of brokers and insurers, and this selective contracting we're going to show is going to limit product assortment in a way that softens insurer competition upstream. I'm going to talk a lot more about this in just a minute. What we're specifically going to do is we're going to link a bunch of different data sources that's going to form links between insurers, brokers, and employers in New York State between 2011 and 2020, which is going to be our market. Then we're going to show you some brief reduced form analyses that are going to be aimed to convince you of three things. One, that brokers steer based on what the commissions are, in the sense that they recommend different plans based on the commissions. Number two, that commissions actually shape these networks with insurers. And number three, that these networks actually affect premiums. Okay, so we're going to hope to convince you of that in the reduced form. Then we're going to take all of this, embed it in a structural model where we're going to try to sort out the equilibrium effects of commission regulations and show you what those regulations might look like. if you take anything away from this paper, it's going to be this here in blue. We're going to find a trade-off here. Essentially, lower commissions in the form of a commission cap is going to mitigate some of these steering agency issues, but through its effect on broker contracts, it might reduce competition. Okay? That's like the basic lesson in a nutshell here. So what I'm going to do now, in our paper, we have this beautiful theoretical mechanism section with all these great graphs and stuff. I am not going to show that here. What I will do instead is walk you through all of this in the form of the Humble flow chart, which will allow you to see not only these mechanisms I'm talking about, but also essentially let me lay out what brokers are actually doing. Yes?
I'm happy the way that this is going to be addressed by the Humble flowchart, but I was just wondering, the way you laid it out, there were no benefits from brokers. So I was wondering if the first best was no brokers, because there were two potential distortions from brokers.
I'm going to address all of that in this
Humble
very
flowchart.
long Humble flowchart. It is not the case that there are no benefits to
Okay,
brokers.
great.
And I will delineate those benefits in just a second. But I agree, probably I should have front-loaded that brokers do definitely have some value. Okay. Anything else on that front? Okay, good. So imagine a very stylized market where you have an employer downstream choosing between two insurers upstream. Now, in our data, we actually have about 3,300 fully insured small to mid-size employers that we're going to be looking at. I want to note here that you should think about these employers not as big universities with large HR departments, but you should think about them as restaurants, construction and manufacturing sites, small businesses, the kind of firms that fully insure and the kind that you might think have bigger hassle costs. Okay? And in our data, we have 10 major insurers upstream. Now, imagine that the employer, all else equal, prefers insurer A. In a world with no choice frictions, that employer is just going to choose insurer A, everything is hunky-dory, and everybody is better off. However, as many people in this room have studied, there are many choice frictions. Employers have hassle costs, they have inertia, they might not know insurer A even exists, and so potentially they might choose insurer B, which we might think is the wrong choice, or they might not offer insurance at all. Here is where brokers come in, and here is the main benefit that they are going to offer to the employers. They're going to come in the middle here. In our data, there's about 700 brokers. Another thing to note here is many of you might be conceiving of these brokers as like these kind of big brokerage firms like Aon or something. This is not that. Most brokers are just some guy that got a license to practice insurance and who hung a shingle down the street. Okay? That's what these brokers are. That's why there are so many of them. These brokers are going to go to the employer and they're going to say, all that stuff about finding the right insurance plan, don't worry about that. We are going to take care of that hassle for you. So their primary role is going to be a reduction in this hassle cost. They're going to fetch the quotes from these insurers themselves and present it to the employer. So remember, these are firms with big hassle costs, and the broker is going to say, we're going to go ahead and reduce those costs. In our data, almost 80% of firms contract with a broker. By firms, I mean employers, by the way. I'm going to use that interchangeably here. Overwhelmingly, they are matched by geoproximity. The biggest predictor of whether a broker and an employer contract is just how far away their offices are. And there is very limited switching of brokers in our data, which I'm going to talk more about in just a little bit. Okay? The next benefit that brokers are going to offer is they're going to potentially improve match quality. So a broker is not just an informational intervention, they're actually making recommendations. They're going to say, we're going to assess your risk, and based on your preferences and your risk, we think you should go with insurer A. And if they are doing a better job than the employer would do themselves, then they're going to match the employer with insurer A, which would improve match quality relative to a world in which those choice frictions existed. Okay, how are these brokers paid? As I mentioned, they are paid by commissions. Now, the way that these commissions work is that there are many different kinds of commission structure, but the biggest one in our data is a percentage of the total premium. So I might say, as an insurer, I'm going to pay you 4% of the total premium from the contracts that you get from me from this employer. These are very rigid in the sense that they do not change over time. These contracts are very, very stable. And they are uniform across brokers, but they vary across insurer and across employer observable. So for instance, insurer A might offer a commission to brokers of 4% of total premiums. Insurer B might offer 5% of total premiums, which is greater than 4%. And as a result, this is where the steering comes in. Now the broker has a financial incentive to steer towards insurer B. That's this steering distortion. Now finally, brokers might also affect employer prices. So imagine a world in which a broker contracted with both of the insurers upstream. They fetch quotes from those insurers. Insurer A charges premium A, insurer B charges premium B. What we're going to show is that, again, there is no requirement that they have complete contracts. Many, in fact, have very selective contracts. So a broker might only contract with insurer A, and now insurer A and insurer B are not actually competing anymore, and this gives insurer A an incentive to raise its premium that they charge to the employer to a higher rate. And all of this is going to be connected essentially by the commission. That's what we're going to show you. Okay, David. Self-insured firms are not in here. Self-insured firms are much less likely to use a broker at all. They tend to do this in-house. And they are much less representative in our Form 5500 data, so we exclude them here. Okay, so let me tell you about our data and setting, and I'm going to show you a whole lot of descriptives here. Okay, so the first thing we're going to do is we're going to build a base panel from the Department of Labor's Form 5500. This is a publicly available data set. Many of you are probably familiar with this. What this data set has is it is required by employers with more than 100 enrollees in any plan to submit to them detailing everything about their benefits. So we have employer identifiers, we have broker identifiers, we have insurer identifiers, we have enrollees, we have premiums earned, we have all of that good stuff. And again, as I mentioned, we're going to be focused on the fully insured market segment with more than 100 employees because that is who is required to submit. Okay? We are going to link that data with data on insurer-broker contracts, literally who every single broker is licensed to actually sell. Where are we going to get this data? There is a third-party firm called Discovery Data that collects this, that we paid a whole bunch of money to get. Turns out all they did was hand scrape the New York State Department of Financial Services website, and badly, so we went and sort of supplemented it with our own hand collection there. And I'm going to show you in a second what that looks like. But this gets us all the networks of who every broker is licensed to sell. We're going to get every insurer-broker commission schedule, literally what every insurer dictates that they must pay the brokers, from a FOIA request to New York State. So we're going to match that on. And then we're going to have a whole series of product attributes for the plans and enrollee demographics and stuff that we are going to merge on through external claims data that we have from a large national carrier where we could actually observe the firm and see all that variation. Kelly?
Are insurer-broker contracts endogenous, or how does that relate?
They are indeed endogenous. They are indeed endogenous. They are.
Can you think about a counterfactual where you remove, like everyone has to have a contract?
We can think about the opposite, where we force everybody onto a contract, which is something, yes, we can indeed think about that. Stay tuned. Okay, so this is what the DFS website looks like, and this is sort of what I'm talking about by these contracts. So this fella here, his name is Bill. He is a retired life insurance salesman. This is straight from their website. You could see exactly when he was licensed to sell insurance, and here on the bottom, you could see the start dates and end dates of exactly the insurance companies that he is selling and when he is active in those contracts. So this is essentially how we are collecting this data. Ben?
Just a clarification, when you said they need licensing, is it licensing per insurance that they're selling?
For every single company, they need a separate license. Yeah. Oh, no, it's not technically a license. It's called a broker of record contract, and it incurs a substantial cost. That's going to be a pretty big driver here. So for example, and this varies by insurer, but insurers, some of them literally require you to periodically take a written test demonstrating that you understand their products.
So I'm curious, just like in this second force and the distortion that you're saying about the choices that are made, considering how much of this is just regulatory because we're imposing these
So it's a fair question. The way that I would respond to that is I would say, even without that, there would still be some sort of soft costs imposed. Let's imagine that you get rid of all of that. If I'm going to be selling a whole slew of whatever, Aetna products, I still have to bear the cost of learning them, and that in and of itself is going to change how I take this analysis. Yeah.
I agree. Just asking, is this something that you can explicitly check? Like, you know how much it costs them if not something, can you do the exercise?
We have no financial data on how much it costs them. It's only something we could infer from our model. So we probably can't do that decomposition that you're asking us. Okay, so let me show you some descriptives here of what this market looks like. So about 70% of our data are fully insured firms, but again, we're going to throw out all the self-insured anyway. And this is all unconditional numbers. So if the denominator is all employer year insurer pairs, 57% use a broker. If you condition on just fully insured firms, it's about 80%. So about 80% of firms in our data use a broker. You could see that the average firm size of the brokered firms is smaller than the non-brokered firms. This makes sense. As I mentioned, the smaller firms are sort of the ones with the bigger hassle costs, who sort of need the brokers more. Take-up rates are slightly higher. That as in individuals within the firm who take up insurance at the firm are somewhat higher. And premiums per enrollee are quite a bit higher among the brokered firms. That could be, this is just a summary statistic, that could be for any number of reasons, but on average they are higher. Now, if we plot, or if we just list the top 10 major insurers in New York State and sort them by market share, you could see a few things. First, the higher market share insurers tend to have higher premiums. That should be sort of no surprise to everybody. What might be more of a surprise is that they also tend to contract with more brokers. So they have a larger sales force. So Oxford United here by far has the highest number of brokered contracts. Right? I mentioned earlier there was limited broker switching. I just wanted to hammer this point home a little bit more. Throughout our 10-year sample, the average number of brokers per employer is only 1.68. About 13% of the data ever in this 10-year sample switch from broker A to broker B. They switch brokers. The ones who do, I actually don't have this in the table, but an interesting fact is among the ones who do switch, 40% of them switch to a broker within a mile from their office. When they do switch, if anything, the average network size of insurers gets smaller. 3/4 to 80% of the ones who do switch end up staying with the same insurer anyway. And when they do switch insurers, only 6% of them switch to insurers that weren't available in the previous network. So to the extent that switching does go on, it seems to have no relationship to the actual insurer in the broker's network whatsoever.
Really simple, just qualitatively, how would a firm like this find a broker? Say you're just starting for the first time.
Yeah, you hire an intermediary to, yeah. So that is again how it would work if you are this big brokerage like Aon, which does exist in markets like New York City and who serve large self-insured employers. The way that, so we have a broker consultant who we have been talking to for this paper. The way that he has sort of laid it out for us is that these are very informal relationships. It's someone that you might see at your local community event or at your local bar or whatever it is. Like these are very, very informal networks that rely a lot on just recommendations.
Yeah, it's very interesting since it's such a big expense for small firms. Healthcare in general.
Yes, well, we can talk a little bit after. I have some sort of non-data related theories about this, but yes. Okay, this is just to show you a few things. First of all, the broker contracts tend to be fairly dynamic. So you can see across insurers here, there's a lot of contracts that just stay pretty consistent across the whole panel. There's a lot of initiated broker contracts and there's a lot of terminated broker contracts. Okay, so these things are changing all the time. And the really interesting thing is on the right-hand side here, I want you to focus on this blue histogram. This is a histogram of the number of insurers that brokers contract with. And what you could see is that the median is about 5. Very, very few brokers contract with all 10 insurers, and about 8% contract with only one. So these are no means complete networks. Right? And this is where a lot of the variation in the data is going to come from. Okay, broker commissions. How is this going to work, and how is this going to aid in identification? So I mentioned that commissions tend to vary across insurers. They also vary within insurer, but across employer observable. Specifically, they vary across total premiums earned and firm size. So basically just the size of the employer, proxied in different ways. For example, you have 3 commission schedules on the left here. On the x-axis, you have total premium dollars of the employer. On the y-axis, you have the percentage that the insurer will pay you for those premium dollars. And you can see that they have these cliffs at different dollar premiums, right? So insurer C, for instance, at around $500,000, it'll drop from 4% to 3%, and so on and so forth. And every insurer has different points at which these ridges happen.
Sorry, is that a percentage?
On all premiums or just the marginal premiums?
It's the percentage of the marginal premium. It's a percentage, for premium dollars, it's a percentage of the marginal
Okay,
premium.
so it's not like a notch.
It's not a notch, it's a kink. Yeah. In fact, on that subject, let's move to some reduced form evidence, again, of these 3 facts that I want to impart onto you. 1, that commissions induce steering. We're going to use these kinks here. Okay? It's pretty simple. Here, we're actually going to do case studies for all of these reduced form analyses. So we're going to focus on one insurer here in particular. They are the cleanest insurer. We see this in our data without being contaminated by other insurer kinks. So we're going to call them Insurer 1. Insurer 1 has a very simple commission schedule. They pay 4% of total premiums for firms with below 500 employees and 3% after 500 employees. And again, because this is a progressive system like a tax, this orange line is going to be the actual incentive that the broker faces. It's going to kink. Okay? So what are we going to do? We're just going to take this insurer and we're just going to say, if we plot the choice probability of this insurer across the firm size, we should theoretically see a downward kink in the probability of choosing this insurer exactly at this 500 point. Okay? That is pretty much exactly what we see here. Yep?
Sorry, just to understand.
X-axis is the number of enrolled employees.
Correct.
Not the number of eligible employees at the firm, right?
It is number of enrolled employees, which if you're thinking, is that manipulable?
Well, I wasn't, before we get to, I was thinking, like, does the broker play any role in, like, explaining the plan to the employees and getting them to sign up? Which, I mean, that's manipulable, but not in a, like, nefarious sense, just in an incentive sense.
Right. So our understanding is that brokers, in fact, do that. We look for a lot of evidence of this in our data, and if they were doing this, what we would expect to see is a bunch of bunching at this cutoff, which we basically just see none of. So that was actually the first draft of this paper, is we were trying to look for exactly that margin, which we, I guess, thought was somewhat more interesting, but we don't really see evidence that that has an effect on this outcome.
Another way you could get at that is based on the characteristics of the firm, you could do like the predicted number of enrolled employees. And if it's about the ex-ante incentives, not the ex-post, then you should see it showing up. I mean, it may be noisier, but in predicted number.
That's a great suggestion. That actually is what we do when we take this to the structural model, but that's a really great point. Thank you. So what we're seeing is a downward kink, as you would predict. And the really cool thing about this is we have a natural control group. We have firms that do not have a broker. And for them, you should see absolutely no change in incentives at this cutoff, so you should expect no kink. And there isn't one. It is just a perfectly straight line. So what we take this to mean is that the brokered firms, where there is an incentive at 500, they kink their probability of steering to this particular insurer, whereas the non-broker firms do not. We can also see where they go. once the incentive to steer drops, brokers tend to go to lower premium firms. This is a very dramatic and noisy graph that I put up here just to show you that something was going on. I'm now going to zoom out the y-axis so that I could fit the control group here. And it looks far less dramatic, but you still see a larger kink in the premiums for the brokered firms than for the non-brokered firms. So steering tends to incentivize you to steer towards more expensive plans. And then finally, a really neat feature of this is we could just see what is your probability of going at this range to the second highest commissioned insurer after this cutoff? And it goes the other direction. The kink actually flips and it rises. So people are just being sent to the second highest commissioned insurer, and they tend to be cheaper. Okay, so we ran this through a battery of your standard kink RD validation and robustness exercises. We can show that there is no bunching, as I just mentioned. We can show that covariates are not only not discontinuous, but are also do not kink around the cutoff. We have placebo cutoff kinks for the entirety of the range. There's nothing there. This thing is robust to any bandwidth, any polynomial order, donut hole decisions. So if you're worried that they can't perfectly predict the enrolled employees like Amy is, we've done some tests based on that. It survives everything. I'm not going to show it to you, therefore you don't know if these buttons are real, but I assure you that they are real. Okay. Fair enough. Okay, so fact number 2 and fact number 3, commissions influence contracts and contracts influence prices. We're going to use a different case study here, which is we're going to move to Insurer 2. Insurer 2 is unique in our data in that it does not offer a percentage of premium contract. It pays per member per month flat fees. And it's also unique because it is the only insurer in our data who ever changed this schedule over time. In 2014, it increased its fees, and then in 2016, it decreased its fees. No other insurer had any changes in its commission structure at all in this panel. Okay? So what we're going to do is just a very simple event study style plot where we're just going to take the share of brokers that contract with Insurer 2 relative to the other insurers at both of these commission changes and just show what happens. So 2014, they increase their commissions. No other insurer does anything. The y-axis is the share of brokers in the market that contract with Insurer 2 relative to the other insurers, and you can see that it goes up. 2016, they decrease this, and you can see that it goes down. Basically, the effect that you are seeing here is for about a 33% decline in commissions, there's about a 5 percentage point decrease in the share of brokers covered. Now, what are we going to do about prices? Here, what we're going to do is we're going to use the same variation as a kind of first stage to see what happens with premiums. So if you imagine the 2014 increase in commissions as like one sort of event, you could have as a treatment group the brokers who did not cover Insurer 2 in the pre-period, right? Because they are, and then the control could be brokers that did. The theoretic mechanism here is that the brokers who did not cover Insurer 2 are more likely to do so now, whereas the ones who did are unlikely to be affected by this mechanism. And if you take the premiums of the other insurers as the outcome, you might see their competitive responses. So think about it sort of using this as a first stage, right? Now again, what you should expect to see is the opposite of this. Networks go up, premiums of other insurers go down. Networks go down, premiums of other insurers go up. Pretty much exactly what you see. Pretty much exactly what you see. It is, in our view, a pretty sizable effect here, particularly in the 2016 decrease in networks. This amounts to about a 5 to 6% increase in premiums when these networks get smaller. Okay, what can we say about this without overburdening you with graphs? We know that Insurer 2's product characteristics are completely unchanged here. Their loss ratio is the same, their deductibles, their coinsurance, their network breadth, and their individual take-up rates within these firms are totally unchanged. We know that treated brokers don't otherwise re-optimize their portfolios. There's no change in any of the other contracts that they're exhibiting. We know that it's not composition. If we limit to the stayer firms in the pre and post period, the price effects stay. And we know they're not market-wide shocks because the price responses actually happen, particularly among close substitutes, in the sense that the insurers with the most overlapping contracts with those brokers are seeing the biggest effects. Yeah, Atul.
So I was curious about your earlier comment that you're going to focus on case studies, and I was wondering how representative do you think these case studies are of sort of universal changes that you see in all the data? Because you probably see a lot of changes in these commissions and things like that.
We don't see a lot of changes in commissions over time, so we can't really speak to how other insurers might react to this. That said, we think that these results are pretty generalizable. We have no reason to think why other insurers wouldn't react in similar ways to this, and we have all this variation in the cross-section as well that we exploit in the structural model. So we think that this is pretty generalizable.
Can I think a little bit about the competition angle? Do firms know who the brokers contracted with?
Oh, yeah.
I think they're getting all 10.
Oh, firms mean employers?
Right, firms, I mean employers. Employers know who the broker has contracts with.
So we have no way of observing this. Our understanding is that, from the broker that we spoke to, our understanding is that firms perhaps have some idea that it is not a full contract if it is not a full one, but they typically don't know the specifics beyond that. The way that we have been taught to think about this is that when you are contracting with a broker as a firm, your primary goal is to not pay any hassle cost whatsoever. This is why you are going with the broker that is closest to your office, and you are just willing to say, I'm going to let you handle this. Right? Yep.
Do you see any differences in the payments between the employers and the brokers, right? Like sort of the incidence of this, like pass-through of commissions or that sort of thing in response to this kind of stuff?
Pass-through of commissions to the employers?
Yeah.
So it mechanically does pass through to the employer. That is actually how it works in the system. So the employer is bearing all the costs of this.
No. I mean in the sense of like now I'll pay you less directly. Like my lump sum payment to you for taking the hassle cost goes down, but the premiums I pay are different.
No, I don't think we've seen this, but this is something that we could investigate a little further, but I don't think so. Yeah.
Wait, maybe I misunderstood. The employer doesn't pay the broker directly, right?
The employer doesn't pay it's indirect. What happens is that the insurer yeah. Oh, that's what, yes. It gets borne out through the employer premium in an indirect way. Right?
But there's no side payment.
There's no side payments. So to be clear, in different market segments, there are side payments. So these sort of big self-insured firms that hire these big brokerages, they work in a somewhat different financial model where there are these direct transactions. Here, that's not how it works. Okay, so what do we know so far? Brokers appear to steer employers towards more expensive products, but decreasing commissions reduce those networks, and a reduction in networks may lead to higher prices. There's this trade-off that I mentioned earlier between steering and competition, and that is what we're now going to investigate in our structural model. So I have 10 minutes, so I'm going to give as brief an overview of this as possible and just show you our sort of simulation results, and hopefully we can talk about more nitty-gritty details like, identification later. Fair enough, maybe I don't need to talk offline. Okay, we have a 40-stage model to present for you here. It's going to flow from the bottom to the top in terms of stage order, and then I'll show you the estimation order afterwards. So we're going to take a commission structure as given. Again, these are pretty rigid over time. And first, we're going to have a menu formation stage where the broker and the insurer are going to form contracts subject to a contracting cost, which we mentioned earlier in response to Ben's question. Then the employer is going to decide whether they are going to use a broker or go it alone. The way that we set this up in light of the limited switching is brokers are not actually competing with each other for the employer's business. Rather, the employer is going to be matched to a broker in their vicinity, and they're going to make an up or down decision based on that broker's characteristics, whether or not they want to use a broker. So our model does not have employers captive to brokers. Brokers have some incentive to do a good job here, but they are not fully competing with one another. Right? Then, after this happens, brokers are going to fetch quotes from insurers for their employers, and insurers are going to set prices. Then, prices are set. Employers are going to choose an insurance plan to offer. Right? Estimation is going to go backwards. First is going to be our employer demand stage. This is going to be a pretty straightforward logit model. We have seen a lot of these before. The few non-standard things here is that this is going to be done from the employer's perspective, not from the individual's perspective. And the employers are basically going to be trading off two quantities. One, what they're paying out in premiums. And two, the weight on enrollee surplus from the plans. How do we get that weight on enrollee surplus? We have a hidden demand model in here with our external claims data set where we observe employees within firms choosing from multiple choices. We measure it there and simulate it in this data set. So we construct this willingness to pay measure for product attributes and demographics. Our steering is going to show up as weights on the premium term. So all the terms in red are these primitives that we're going to estimate in this model. We're going to estimate this row 1 term, which we're going to call a brokered wedge. So how much more or less price sensitive do brokers make employers, given their realized choices? And then this alpha 2, which is going to be explicitly a function of the commission. So how much does variation in commissions affect your realized price sensitivity? This can sort of be thought of as like a joint broker-employer objective function. And we're going to be using realized choices and the same identification as the reduced form, this variation within insurer over these observables to basically get these parameter values out. The insurer price setting is fairly standard. It's just a first order condition that we're going to invert to recover marginal cost of every single firm. Ben?
Do you want us to think about the brokerage wedge as a driver of selection or something that like usually the broker makes you less?
We absolutely cannot disambiguate. We cannot in the counterfactual, we are going to be very conservative and just assume it's like selection. We're not going to like touch it. Yeah, we're not going to touch it. Just for conservative reasons. Yeah.
Is the broker influencing, is it the commission and the networks that are influencing it in that alpha 2 gamma?
It's just the commissions. It's just the commissions. The network is going to be coming in the employer choose broker stage.
But it's coming in the last stage in
The choice set is coming, yes. It's only among the...
once you pair up with a broker, you can't go to a firm they don't deal with.
Correct. Correct. Yes. Okay. Whether you use a broker or not, an employer is just going to take its surplus from the set of products a broker can give them with that broker's formed network versus them having the full network of insurers to choose from, but also a hassle cost F to pay. So the way that we're conceptualizing this is if you go it alone without a broker, you have to pay a hassle cost to essentially see the full information, and then you're going to choose from among this big set of products. Yep? Anecdotally, yes. In fact, not only yes, we took it away from the slides here for time reasons, but we have a direct quote from a broker that says they do exactly that. And then finally, the broker menu is going to be formed. This is just we're maximizing broker profits over its expected networks, and we're recovering contracting costs, which we're going to do with these typical moment inequality one-step deviation things. Okay?
Does it matter in the last equation for that like if they see like if they have to see the whole choice set? I'd imagine if they had hassle costs, they'd probably not see the whole choice set.
So we have thought about this, and there are ways we could potentially relax this and sort of think about modeling the choice, the hassle cost as an explicit function of how much of the choice set they want to see. So far, we have not dove into that just for tractability reasons, but that is absolutely something that we could be thinking about, yeah. Because this is essentially assuming that, you know, you have full information subject to some costs, and it takes away any kind of behavioral issues. So I totally agree. Okay, here is the full model. We need to identify the broker steering wedge. We need to identify the marginal cost. We need to recover the hassle costs and the contracting costs. In the last few minutes, I'm going to ask you to just trust me that this stuff is identified. But again, we use instruments. We use variations similar to the reduced form, specifically in commission changes. And I want to just give you some numbers here. So employers without brokers, we basically see that they value about $1 of employee surplus at about $1.32 of their own premiums. This is actually pretty good. It's basically saying that without a broker, you know, modulo the tax exclusion on health insurance, you're about weighting these things the way that we would think a sort of rational firm that could freely adjust wages perhaps would do this. Brokers tend to raise this to about $1.56 with low commissions. With high commissions, it goes up to about $1.67. So the way to think about this is that relative to a firm without a broker, brokers increase spending per dollar of employee value by about 25%. So it's like for the same exact dollar value, they're increasing spending. So they're basically making employers less price sensitive in their choices. We could show you that the hassle costs we recover are about $70,000 a year for an average firm in New York. Funnily enough, if you go on Indeed.com, this happens to be about the average salary of a benefits administrator in New York City. So we think the ballpark magnitude is pretty nice. The insurer marginal costs fit a very nice loss ratio, and the broker contracting costs are about $1,000 per month per insurer. Right? Now, in the last 2 minutes, I'm going to skip a lot of this stuff. Let me show you two things very quickly. Here, we're going to do a decomposition where we impose a counterfactual commission cap at 1% commissions, which have been some of the more aggressive proposals we've seen. And we're just going to see what happens to employee willingness to pay given turning a bunch of channels on. What we can see if we let employer choice patterns change alone, not all that much happens. If we then let insurers reprice based on those choice patterns, a little bit happens, but not all that much. Where the real action is if we let employers fiddle with their decisions with whether they actually use a broker or not. And the reason this affects the employees, the way to think about this is now that steering is effectively gone, this changes the employer's willingness to use a broker, and that actually on the extensive margin makes them more likely to offer insurance at higher rates, which increases the employee surplus. So that is where most of the action is coming from the employee perspective. It all gets swamped by the decrease in networks and the increase in premiums that comes out with this. Okay, so we find that this anti-competitive distortion is actually much more prevalent here in this market, and you can actually see this if you regulate this across different commission caps. You could actually see, obviously, the surplus from less steering is just monotonically increasing. Obviously, the surplus change from less competition is monotonically decreasing, but the total actually has this U-shape, suggesting that there is an optimum. And in scenarios where we assume that non-profitable brokers actually exit the market, you could actually see total surplus decreases if you regulate this too far, just driven by these anti-competitive effects. We did a bunch of stuff in this paper. We showed that there is a trade-off. Happy to talk more online. I am exactly at time, so thank you for your attention.
Thank you, Nick. We will break for 15 minutes and reconvene. Much. Welcome back. We are very happy to have Riley League. You have 5 minutes uninterrupted.
Thank you very much. Well, I'm really excited today to talk about why it's so frequently the case that when you go to the doctor gives you some health care, they package that into a claim, send that claim to the insurer. Why is it the case that so frequently the insurer ultimately does not pay that claim? Right? We want to understand why there are so many denied health insurance claims in the U.S. healthcare system. And we think this is an important question for a couple of reasons. So the first is that this is really costly. So administrative costs in the U.S. healthcare system are extremely high. Most estimates put it at about $1 trillion a year, about a quarter of everything that we spend on healthcare going towards administrative costs, with most of this being billing and insurance-related activities, right? Things like claims management, clinical documentation, coding, prior authorization. And this is where the cost of claim denials fits in, right? The costly back and forth of submitting and resubmitting claims by providers to insurers where this lives. Not only are these things very costly, but they're also extremely controversial. So this is a picture of Brian Thompson, the CEO, a former CEO of United Healthcare, who was assassinated about 1.5 years ago, sparking a nationwide debate about whether it's acceptable for insurers to deny paying for healthcare. And I said they're controversial, but that's actually not true, because everyone agrees that claim denials are a huge problem, right? If you're a Republican, Democrat, no matter your income, no matter your insurance, everyone thinks claim denials are a huge problem. But the motivation that I think is maybe the most interesting for this room is that we think that claim denials are a bit of an economic puzzle, or at least their high prevalence is. Now, we know that the high-level rationale for claim denials, or for threatening to deny claims, is to control costs by denying medically unnecessary care, right? The insurers can't pay for everything, so they need to be able to say no. And with the goal being to deter the activity, the care that the insurer doesn't want to pay for. But the fact that we see so many denials getting realized indicates that this deterrence isn't working, right? Providers are regularly billing for care that isn't ultimately paid for. And that's sort of surprising, because you would think that the providers would internalize these rules, and if they're able to know what care the insurer will or won't pay for, they wouldn't render and wouldn't bill for the care that they're not going to get paid for. If you think that there are reasons that providers might do this, or that providers might just make mistakes, the question then moves up a level to think about, in private health insurance settings, which is what we're going to be focused on today, why is it that the contracts with high realized billing frictions persist in equilibrium? Right? For sort of coast-bargaining type reasons, you would think that insurers would be incentivized to invest in sort of avoiding all of these things. They could transact the same amount with the providers, but saving administrative costs on both sides, just transacting at a lower price. Okay? And what we're trying to ask in this paper is, why doesn't that seem to be happening? Why do we see so many claim denials in our system? And we're going to answer this using the Massachusetts All-Payer Claims Database. And we're going to first present a few stylized facts that we think any sort of model of claim denials has to grapple with. So the first is that there are lots of denials. So they're prevalent across payers and over time. We see this in every market segment, lots of claims getting denied. We also see that the denial rate is higher for lower cost care. Okay, so it's not the case that really expensive stuff is what's getting denied all the time. It's the cheap stuff. And the third thing is that denied claims are commonly nearly certain to be denied ex ante. That is, many of the claims that get denied are submitted to insurers that basically never pay for this stuff, okay? Which we then sort of try and write down a model to think about what can explain these patterns and what can't. And the base model that we consider is one of denials being based on clinical appropriateness. Right? The provider is perhaps upcoding some patients, treating patients who don't need it. The insurer is deciding how much scrutiny to give it. And this actually can't generate the patterns that we see. Right? In fact, it generates many of the opposite patterns of what we see, which we think points to a model of insurer fragmentation leading to billing mistakes and miscommunications, right? Where there are lots of different insurers, each with different billing rules, different coverage rules, where providers have a limited ability to follow those rules and tailor their billing across insurers, leading to the patterns that we do indeed see, okay? And so given that we think that this can be an explanation in theory, we then turn to providing some more direct evidence that fragmentation seems to be an important explanation for lots of the claim denials that we see. And we're going to think about sort of two aspects of insurer fragmentation. One is on the enrollment side. We're going to show that folks with more complex insurance arrangements tend to get more claim denials, and that these denials spike very dramatically when people change insurers. And then we're going to think about the presenting evidence that insurers differ in the way that they cover these services while providers bill in a coarse way. Wow, I nailed the 5-minute thing. Yes?
Just a clarifying question and then another question.
So clarifying, when you say denied claims are nearly certain to be denied ex ante, presumably what you're saying is if that's true, you can predict it based on the insurer, but if you had a random chance of being at one of 10 insurers, you'd have a much worse ability to predict denial?
Yeah, that's exactly right. Yeah.
And then, sorry if I either missed this or I'm just, totally out of it, but I would have thought it's mostly not people submitting insurance claims, but providers.
Yeah, that's exactly right. Yeah, so basically everything that I'm going to show you here is going to be thinking about when I say people, people that are doctors.
When you say when people switch insurers.
Yeah. So when an enrollee switches from insurer A to insurer B, the claim submitted on that enrollee's behalf for that enrollee's care spikes.
So this is someone who was previously going to this provider, and then they get more of their claims denied. Is that what you're saying? Because
If I'm enrolled with United,
Yeah.
and then I change to being enrolled with, Aetna or whatever,
Yeah.
I get more claims denied. Now, what we haven't done is, differentiate whether I change providers or anything like that.
I guess another way of saying it is I would think, one prediction would be you'd be more likely to get your claims denied within the same provider because they've kind of figured you out as a heavy user.
Yep.
But the other would be that if some providers have, say 100% of their patients is in one insurer, then they should have much lower denial.
Yeah, so in the cross-section, we do see that.
Cool.
Yes, that's exactly right. And hopefully I will have time to get to that. But yes, that's right. Okay, so just by way of background, people understand, sorry.
I just want to quibble with your framing a little bit because you're taking quite literally that there are claims in your data that were denied. But whatever his name was angry about was care that didn't happen because of denied prior authorizations, which is not what you're seeing at all. You're not even looking for that. That's a very different concept than what you're measuring.
Yeah, no, I completely agree that prior authorization. So this is actually an important distinction to keep in mind is that when I say claim denials, what I mean is the care being paid for, which almost always is after it is rendered, which is very different from thinking about prior authorization, which is another way of sort of denying people from getting care,
To your motivating slide with the
that people don't like them.
Yeah, well, because of the shooting.
What they're complaining about is a completely different concept than what you're measuring. What they're talking about is delayed, denied, whatever. They're not talking about, I went to the doctor, and then the doctor didn't get paid. I'm so upset. They're saying I didn't get the care that I wanted because, so it's just
Yeah, that's fair enough. If you don't like motivation 2, hopefully motivations 1 and 3 were enough to get you on board. That's exactly right. Yeah, that's exactly right. So this is all going to be after, basically you should think of as after the care is rendered, fighting over the getting paid. Okay, great. So the first thing I want to highlight is just, we all probably have a sense of this, but just how fragmented much of the U.S. healthcare insurance system is. So if you think about how people get insurance, if you're old, you get Medicare, and that actually has a few different flavors. And if you're a little bit younger and better off, you'll get it through your employer. If you're a child, you might be a dependent on an employer-sponsored plan, or you might, if you're low income, qualify for CHIP or Medicaid. If you're too old for CHIP, you might still get Medicaid if you're sort of low enough. If you're old and low income, then you would be a dual eligible. The ACA came along, slapped this big Band-Aid in the middle and said we're going to cover people with the individual market, right? And what you end up with is a complicated system where if you're a provider treating patients in all of these market segments, you could end up having to deal with a lot of people, right? But that's not it, because within each of these market segments, you're going to have a ton of different insurers, right? And these are in Massachusetts, it's generally there's sort of one big insurer that has about half of the market, and then a few smaller insurers, along with a long tail of very small insurers. But even that understates the degree of fragmentation or differentiation along these dimensions for the insurers, because each of these is going to have tons of different plans, which might have different requirements for the way that they want things billed and the services that they cover. Okay? So from the perspective of a provider, this can be a pretty complicated system. Now, for the data that we're going to use, we're going to look in the Massachusetts all-payer, yes?
So, in other countries, there are other countries with multi-payer systems.
Yep.
That regulate pricing. They also regulate, do insurers have no discretion about what they accept or not? Why is this a problem in places that have multiple, like Switzerland, and multiple insurers?
Yeah, so I think, well, man, I wasn't ready for questions about other countries. No, so I know that in certain other countries that they do like smooth out some of these frictions. I'm not sure exactly how regulated the sort of different aspects of the plan design are. I mean, I think that even within the US, you can think of there's different degrees of within a market segment, how much you're allowed to sort of differentiate. My sense is that in other countries, there tend to be sort of more harmonization of everything, right? Like, yeah, it's a good question.
My understanding is that a lot of denials get approved on appeal.
Yep.
Are these the first denials or the final denials?
Yes, good question. So here, I will push that for the next bullet. Here, I'll even put it up there while I talk so you can just read it if you, although it might not say. So basically, we're going to look in the Massachusetts all-payer claims database, which is great because we see all the insurers, except traditional Medicare, which we don't see, and after 2016, self-insured employer plans are no longer required to submit. Many of them do. It's the almost all-payer claims database. Yeah. So it depends. It's in practice, it seems like patients pay very little of this in terms of sort of the financial incentives of the provider. It looks like if you don't get paid from the insurer, you're very unlikely to get paid by the enrollee. It is also not entirely clear in what cases they are even allowed to submit the bill, but from the perspective of the provider's financial incentives, you should think that they can more or less ignore any money they might get from the patient. I do not. So yeah, so we observe denied claims. We observe what we're going to look at is the ultimately did it get paid or not. So fully adjudicated versions of the denial status. We do, in certain circumstances, see sort of earlier versions of the claim. We don't trust that data a ton, so I'm not going to rely on sort of the initial and the appeal. We're going to be thinking about whether you ultimately get paid for this. And the other sort of, I guess, explanation of what data we have on denials that I want to highlight is that there are certain classes of denials that are not required to get submitted, sort of full denials where they deny sort of all the lines on the claim outright. And so those aren't required to get submitted, but it does look like almost every insurer submits at least some of these, but we don't know that they're submitting all of them. And so we're going to be very careful about sort of cross-insurer comparisons in the overall denial rate because we're worried about misreporting of this class of denials. Yes?
So denial of paid is there's a spectrum between those, right, of down coding or other negotiated rates. You sort of, if you don't trust the other data there, can you do anything with that spectrum?
Yes, but what would you like us to do?
I mean, I would like you to have more than two outcomes in terms of what the insurer does. Or
I see.
Some more clearly defined line between denied or down-coded or paid at such a low number, it's basically denied in first order.
I see.
Versus paid at something close to what was originally the negotiated contract.
Yeah, that's a good question. We've looked at this. It looks like if you condition on, we see sort of two versions of the claims. It looks like if you sort of exclude was it ultimately paid or not, like at zero, that the price doesn't change very much. And so I don't think it's nearly as large of a phenomenon as the out and out, we're not going to pay for this at all. But yeah, that's something we could look into. Yes, that we can tell. Yes, that's right. Okay, and then the other nice feature sort of that I alluded to earlier is that we can see almost the full health insurance landscape, we get to follow patients as they change insurers. We get to see providers billing multiple plans, multiple insurers, something we wouldn't see if we just looked within one insurer. Yes? How much is fraud? Oh, great question. I'm not sure. Yeah. You know what? They're actually, it's great data, so it might be there. We haven't checked. Yeah, it's tough. I mean, I think that, so that actually gets back to sort of, you know, later when I talk about sort of how you can think about modeling this, if you think about fraud prevention as basically being we're going to try and detect the medical necessity, that's sort of a way you could build in. What I'm saying, what we're going to say later when we get to some of the modeling is if you thought all of this was about fraud detection, that can't explain the patterns that we see. That doesn't, of course, mean that there aren't lots of denials that are because they're actually detecting fraud. Yeah. Okay, good question. Okay, so now some of these descriptive facts. So these are basically that there are lots of denials, that we see there are fewer denials the more expensive the procedure is, and that it looks like you should be able to tell if the claim is going to get denied a lot of the time even before you submit it. So remember, I just told you cross-insurer comparisons you should be wary of, but this is the overall denial rate across the sort of big market segments in our data. And the point that we want to make is that it's quite high in every market segment. Right? So I don't want to make anything of the fact that we see, 2 percentage points more in Medigap than Medicare Advantage. But the point is this is not only a problem with Medicaid, or at least not only a phenomenon in Medicaid. Right? We see high denial rates sort of in multiple market segments. This also is something that I don't think anyone would have thought, but it's not something that's going away. We see in our data period, which is 2013 to 2020, about 13 to 16% of claims getting denied every year, or in any period. Okay. The interesting thing, the first really interesting thing, I think, is that we see that denials are more common for lower priced care. So this bin scatter is the average price of a procedure, conditional on when it is paid, against the denial rate for that procedure. And I've excluded things that cost less than $5, which actually have a very high denial rate. And what you can see is that there's basically a monotonic relationship between the price of the procedure and the rate at which it's denied, which I should emphasize is, varies quite starkly from the notion you would get from popular coverage, where people talk about claim denials focused on those with really high medical and financial stakes. Both those sort of talking about prior authorization, but also those looking at sort of the reimbursement of these procedures after the fact. Yes? Yeah.
So can you look at appeals rate by side of claim?
Yes. Yep. Yeah, that's right. So like I said, we don't love the sort of appeals data that we have, but taking it at face value, it does look like that is positively sloped with relation to the price, which makes sense. Now, I think, and as you'll see in the model, sort of that's exactly what we think is going on, that it's not about detecting whether you treated the patient correctly or incorrectly. It's about this denial slope is going to come from the fact that only for the expensive stuff are you willing to figure out, for this insurer, how is it that I actually get paid? Great. Okay, the third fact is that these denials are often predictable. So I'm going to show you a lot of histograms that look like this. So to take a moment to show you what we're looking at, this is the denial rate of an insurer for that specific procedure in that quarter, weighted by the number of claims that get submitted. Okay? So the median claim gets submitted to an insurer that denies that procedure code in that quarter 6% of the time. Okay? So most claims are submitted, down here to things that don't get denied that much, but some of them get submitted to insurers that very, very rarely pay for that. It's about 3% of claims. And as you would expect, this represents a hugely outsized share of the denials that actually happen, right? So if instead of weighting by the number of claims, you weight by the number of denials, though the median denial rate for a denied claim was 42%, and about 20 to 25% of them are submitted to insurers that deny that claim over 80% of the time. Yes?
If you dollar weight that, is that still, are these all the super cheap $5 super cheap denials?
If you dollar weight it, I'm not sure. It's a good question. I mean, so you definitely see less of this stuff for the more expensive care. I'm actually not sure sort of how this ratio changes. Yeah, that's a good question. That's a good question. Yes, I would expect that it would be more common for the cheap stuff. I think that's exactly what to expect. Yes. Great question. So let's see. Do I have the list of super? So if you look at the most denied procedures, right? It's cheap stuff that isn't the sort of stuff that we think is super overused, right? Blood connection, like a blood panel. Office visits, just because there are a ton of those we see are commonly denied, but the denial rate for them is quite low, right? It's lots of stuff that we don't think is sort of super prone to abuse, super like high financial stakes that some insurers don't pay for. And I'll get later in the talk a little bit more about sort of why we think they're not paying for it. Yeah. Okay, so I don't have anything about that in the slides. I don't think a lot of it is out of network. In part, and now we could do more on this, but in general, it doesn't look like the denial rate for out of network claims is meaningfully higher than for in-network claims. Like it seems like they process it as oh yes, wonderful, like great, clean claim. We're not paying, like somebody else is going to pay for this, right? Or like you have to pay for it at some exorbitant cost, that sort of thing.
I believe that I've seen data, but I can't say where, that these are also the most denied claims in traditional Medicare.
Yeah, well, yes. So I don't know I would believe that in particular because, well, you see a similar like relationship between the price of the procedure and the denial rate in traditional Medicare.
Where did you get those data?
Yeah, I've written a paper on denials in traditional Medicare, and yeah. Yes, there we go. So it's not just Massachusetts, yeah. Uh-huh. Mm. Yeah. Yep. Yeah. Great. I'm glad I haven't built the paper around it, because I bet they're skeptical thoughts would be my guess. Yes.
Just an observation, part of the reason for the downscoping nature is that physicians will get prior auths for the most expensive stuff. So you're not likely to get denied. You're not going to take on the risk of an expensive procedure not getting it.
Yeah, I think that's right. So yeah, so we don't observe prior authorization, and you might think that prior auth is used much more commonly up here. A couple of things I want to say about that. So first, if we sort of look at classes where you think that there's like tons of prior auth, like therapy or something, we still see lots of claim denials there. Like it's not as if we're sort of perfectly substituting between those things. The other point that I want to make is that particularly during our sample period, like prior authorization on procedures was somewhat less common than it is now. Yes.
But a related thought to that, which is, I mean, I also had your intuition that it would have been the bigger claims that were denied, but now that I see this, like one thing is, again, if your model is one in which, the provider is uncertain about exactly the rules of your insurer, but they're kind of aware that they're unsure, they're more likely to check.
Yeah, that's exactly right.
Doing a large
Absolutely.
thing, but if it's like, maybe the $5 we don't get,
Yeah, no, that's exactly right. That's exactly right. Okay, great. So now to talk a little bit more directly about that model. So sort of the base model that we have is one where insurers are going to scrutinize claims, and they're going to endogenously choose the amount of scrutiny to apply to that claim to see if it's inappropriate or not, while the provider is deciding which patients to treat, and they differ in sort of their need for the service, right? And so denials happen when the provider treats somebody who doesn't need the care, but the insurer sort of checks enough that they detect that, okay? The denials can also arise because either the procedure just is not covered, or because there's some mismatch between the billing systems of the insurer and the provider. And this, we're thinking very broadly in sort of the way that you communicate the medical documentation. Does it match sort of what the insurer wants? You could think of it as they speak slightly different languages, okay? And focusing sort of first on the sort of just insurers that's scrutinizing claims for inappropriate care, this actually can't generate whatever I just showed you. So in this model, you're going to get the denials are increasing in price because, one, providers are going to overtreat more the higher the price is, right? They're going to have incentive to overtreat. And the insurers are going to apply more scrutiny when there's a higher price because they are more worried about the money walking out the door. And both of those are going to cause the denials to be increasing in price, whereas what we see in the data is that they're decreasing in price. The other thing is that in this model, you're not going to be able to get 100% denial rates because the provider is going to see that if there were endogenous somehow a 100% denial rate, the provider wouldn't render that care, okay? And so the providers are going to internalize these billing rules, and denials in general should be quite low, which we think points to mistakes and miscommunication being the major source of denials, right? So it's not, you can't just get it with insurers checking whether it's medically necessary. You need some of these other things that we're calling mistakes and miscommunication type denials. And as an aside, I should also say that this matches what you would get if, what we don't have, but in other data, you looked at what they say the reason for the denial is, right? So you might not be able to see this, but this is registration and eligibility, right? Problems with enrollment, missing data, right? Medical documentation, right? All the way down here at 7% is where we see claim denial, or medical necessity as a reason, right? So these sort of purely administrative type denials are what seem to be commonly the case in data that have these reasons. And what we're saying is that also is what you might expect in an economic model. Now, why are there so many mistakes, right? That's an equilibrium outcome. What we're going to argue is that one way you can rationalize all of these mistakes is through insurer fragmentation. Right? So if you have multiple insurers that differ in their coverage rules, their billing styles, the requirements that they have for documentation and so forth, while it's costly for providers to tailor their billing to each insurer, that can in fact match the patterns that we see in the data. Right? And this is because while some insurers don't cover a procedure, if other insurers do, and it's costly for the provider to change what they're doing across insurers, then they'll bill for care, they'll render care and bill for it, even if this insurer doesn't pay for it, because maybe this insurer does. And that can generate sort of the 100% insurer level denial rates that we see in the data. Similarly, if the provider has to sort of choose the way that they document their care, and the insurers differ in sort of the way that they want that, the providers are going to choose an intermediate billing style, which is going to lead to widespread denials, including for those procedures that don't have any overuse concerns. Yes?
Why is another model a scummy doctor model, where I forget what you're thinking with denial all the time with the blood test?
Yep.
I know I really shouldn't give it. I'm going to always order it, figuring I'll get through sometimes and I'll make some money because I haven't lost anything. So, and that model will be consistent with your facts. So, and I guess the way to test that is, are there doctors that across insurers always billing for the same stuff that's getting denied?
Yeah, no, I think that's right. Now, a couple of things I want to say is, first is I agree that the doctors are only billing for things because in expectation they're like going to get paid for it, from somewhere, right? And I also think it's correct that like the dummy doctors are like they're not maybe fully internalizing all of the incentives that the insurers are giving them. I think the one thing that I do want to point out is that even the sort of submission and appeal and all that process on the part of a claim, which we do, not as frequently as for expensive things, but we do observe happens for even the low price things, that's going to be directly costly. Yes?
So I'm hazarding a guess on your highest thing being Medigap, which would be traditional Medicare, because you submit your bill to the supplementary insurer. And I think for the blood stuff, but I'm not sure, Medicare may want it all bundled. And
Yeah.
they're billing separately. Now what's puzzling is that most all providers have a billing clerk or clerks.
Yeah.
And you would think that Medicare is a big enough share of practice that the billing clerk at least would figure out how to bill a blood test.
You would think, right? But that actually, the fact that you say, oh, well, Medicare is the biggest one, so they should figure it out, that's actually something we see in the data that as providers have more volume sort of overall or with a given insurer, that they do get fewer denials.
I think you submit your Medicare, I think they submit the Medicare bill to the traditional, to Medigap first, and then it goes on to CMS.
Yeah, I think that's exactly right. And I think that, so one of the things that I'm going to show is that in general, folks with more complex insurance arrangements, like people in Medigap, sort of even.
Medigap is not, it's very simple. I mean, Medigap is just covering the co-insurance.
Well, sure, that's right. Yes, yes, that's right. Okay, and so then the last thing is that sort of as John was talking about, if you see like providers are only exerting this effort for the high-priced things, sort of making sure that they're treating the right patients and tailoring their billing correctly, you're going to get, you can get a negative relationship between the price and the denial, which is exactly what we see.
This seems to me, you had a lot of miscommunication, but it seems to me it's mismanagement. And a big part of that, the main question is, why don't insurers coordinate that?
Fantastic question. So that's one of the things that we think is sort of nice about the insurer fragmentation story, is that it makes it a coordination problem. It explains like why this thing would persist in equilibrium, because prices could even adjust to address the overtreatment incentive if you thought that were possible. And yet we can end up in a coordination failure area where every insurer is sort of in the middle of their providers' languages. Every provider is in the middle of their insurer languages, and so everyone could be better off if we were able to fully coordinate, and yet that's, we're stuck in a sort of a local maximum, I guess.
Yeah, but I think that's it also suggests maybe some kind of externality that the investment in
Yeah, that's exactly right. I think that's exactly right. I think it's sort of a similar sort of way of thinking about this. No, I think it's extremely relevant. That's right. I think that it definitely also sort of lowers the incentive to invest in sort of smoothing out this process from any given insurer. I think that's exactly right. Yes. Okay. So now I've sort of argued that fragmentation can potentially, in theory, show us what we observe. Is that actually what we see? And the two aspects of fragmentation I'm going to think about are on the enrollment side, and then on the rules that the insurers have side. So on the enrollment side, first I want to show that when enrollees change from one insurer to another, that there's an absolutely huge spike in the claim denials that they face. Okay? So these are event study coefficients comparing folks who change insurers to those who, and at the same time, do not change their insurance. And what you can see is that there's a spike in denial rates of 5.5 percentage points, which for this sample of folks who are switching is about a 50% change relative to baseline. And this isn't also like some weird backwater of insurance. 10% of individuals change insurance every year. Right? So this is a common occurrence. Now, to further unpack what's going on, you may think, well, is this about sort of learning the new rules of the provider, or is this something even simpler where I'm just billing the wrong insurer? And as it turns out, if we restrict only to claims submitted to the correct insurer, about 2/3 of this initial spike is them sending it to your old insurer, right? So silly stuff, right? The silly stuff adds up, right? But what we can see is that even making this restriction of, you correctly figured out who this person was actually enrolled with and sent them the bill, that there's nonetheless this spike and then this sort of gradual decline, but actually settles at a higher level, which by 10 months after is basically all of that excess is coming from sort of we've worked out who we should send the bill to, and yet we're still getting additional denials. Yes?
What's the mechanism for billing the wrong insurers? Is just the patient shows up with your old insurance card, and that just seems like, that's not really billing, that's like front of office stuff.
Yeah. I mean, obviously we don't see why exactly this is happening. I think that largely is what's going on, is they're just sort of operating on outdated information, potentially because the patient, again, continues to bring the incorrect insurance card. But sort of the point we're making is that sort of small friction is sort of a product of sort of the fragmented nature, and it also points to sort of broader issues. Yes?
Some of the 10%.
Mm-hmm. Yes. Oh, that's a good question. Yep. Yep. That's right. We don't. I suspect that's true, but we should look at it. That's a good question. Yes. Okay, so very few denials of folks who, actually, I don't know if I've done this exact event, but a related question is we see folks who are duly enrolled by multiple insurers, so, accepting like I'm a dual eligible with Mass Health, like I'm the dependent on my spouse's insurance and I also sort of carry two types of insurance, that those folks see many more denials. And in this sample, these folks aren't more likely to see like the same claim submitted to both insurers for the same care. So it doesn't look like a lot of it is, well, I sent it over here and I sent it over here, like literally for the same person and I'm getting paid over here and not there. Oh yeah, well, you would hope. I mean, this is a very lossy process, right? Like claim submission is not free. Yeah. Yeah. Yeah, like if I dollar weighted this, how different would it look? That's a good question. Yes. Yeah, so that's this line here. So yeah, actually, this entire sample here is folks who have exactly one insurer that they're continuously enrolled with for 10 months, no break, no overlap, then the same, like another 10-month continuous enrollment with So like, this is sort of the cleanest possible I'm going to change insurers way, and even here we see this big spike. Sidestep some of these issues. Okay, great. So again, people with more complicated insurance arrangements, with dual enrollment, in the cross-section, see 10 percentage points more denials, even if we residualize on the insurer that they're getting submitted to by the procedure that is getting submitted, we see higher denials. Okay, so now thinking about the differences in the actual rules that the insurers have. So, insurers may have different rules for both whether they cover a procedure or not, and how they cover it, okay? This doesn't always have to be, wow, this is some expensive drug that we never want, I mean, we're not looking at drugs, but some expensive procedure, experimental thing that we're never going to pay for. Lots of it can be, well, are we going to pay for this separately or bundle it into a larger payment? Are we going to cover it under a medical benefit, or is this a thing that we carve out to like a vision or a dental or a pharmaceutical benefit, right? Do we restrict this to a specific provider network, right? There's all sorts of these dimensions on which these insurers and plans can vary. And of course, if the providers or their billing staff have a limited ability to either know in the first place or to follow these insurer-specific rules, then we could end up with providers billing in a coarse way. And if that's what's going on, which is sort of what the model thinks would be going on, we would expect to see first that there are denials for services that the insurance rarely covers. That I've already showed you. You would also expect to only see that when there are other insurers that are happy to pay for that service, okay? And what that's going to generate is sort of a bimodal distribution in the denial rates across insurers, right? So taking an example here of a commonly denied procedure, refractive eye test, right? This is like A or B, right? Which looks better, right? It's common, it's $150, right? It's not like super expensive, it's not something that we think is super overused, and we see that it's denied a lot, right? About half of these claims are denied. And what's striking is this bimodal distribution, right? There are 30% of claims getting submitted to insurers that are like, yeah, great, like less than 5% denial rate, looks good. And then there's another 20% that are submitted to folks who say, we are never going to pay for this. Like, why are you sending us this bill? Okay? And this sort of bimodal pattern is something that we see in different, many of the highly denied procedures, right? Capillary blood draw, cheap, not prone to overuse. Lots of people don't pay for it. Some people do. Pulse oximetry tests, same story. And so what we want to know is how prevalent is this bimodal coverage pattern, right? I can't look at this distribution for every single HCPCS. And so what we do is we say, well, we're going to classify you as a bimodal procedure if you satisfy two conditions. The first is that you're more two-peaked than one-peaked. Thank you to the mathematicians, I guess Sarl, for coming up with some coefficient that tells you whether you're more two-peaked or one-peaked. And then also that there's a meaningful gap between sort of the two peaks, right? So if the 10th percentile claim gets submitted to an insurer that differs from the 90th percentile insurer by at least 50 percentage points, right? So big gap between the top and bottom of the distributions. We're going to call that strongly bimodal. 10 percentage point gap, we'll call that weakly bimodal. And this is actually super common, right? So the stronger definition, we see that that's about a fifth of all claims submitted are for services that have that shape of a distribution, representing almost half of denials. And if we use the weaker definition, it's actually about half of claims and about 2/3 of denials. So first, these are disproportionately claims that are getting denied because the share of denials is more than the share of claim lines. And also, it's very common to see insurers having very different denial rates in this sort of bimodal sense. The other thing that I mentioned is that you would expect to see these high denial rates only when there are insurers that pay for the procedure. Now, what this means is that if we take the overall distribution of submitted claims, right, there's not that many that are submitted to insurers that deny a ton. And we said, what if we condition on this is a procedure that has a high denial rate? Okay? There are two ways that could happen. One is that the entire distribution could shift to the right, which is exactly what you would think if it was about, well, this is something that, for any given patient, there's more uncertainty and we're going to disagree within an insurer. Or it could be that there's more people who say, we're not paying for this. And if we look at procedures that overall have a 30% or higher denial rate, we see that it's not a shift to the right. It's a bunch of people stay down here, but now there's more insurers that almost never pay for this procedure. If we condition on a greater than 50% denial rate, the same thing. And in particular, notice that these super high denial procedures, the most common thing is someone says, we're not going to pay for it. But the second most common thing is someone says, oh yeah, we pay for this almost all the time. Right? It's not a model of people being uncertain in the middle. It's a model of, well, there's differences in who pays for it. Even for high denial procedures, many of the insurers rarely deny the claim. The last thing that you might expect is that if this sort of tailoring cost or the ability to sort of follow an insurer's rules can be lowered with more experience, that there should be basically, learning by doing in terms of billing. And in the cross section, that's exactly what we see. So if you look at providers with higher billing volume, they tend to have lower denial rates, okay? Even residualizing on the mix of things that they bill for, right? And this is true if we look at sort of the bilateral volume between the insurer and the provider, and then if we condition on sort of the overall volume, right? So providers with sort of more concentrated mix of insurers tend to have fewer denials than those with less concentrated. Yes? That is a good idea. Yes.
If you progress the claim denial rate on a provider fixing
Uh-huh.
what is the R square? Or how much of this is explained
Oh.
because some people are bad at this?
Good question. I think first, if you're going to have insurer by procedure fixed effects, once you do that, I think quite a lot of it. I don't know the R squared, but I have done the sort of that value added thing, and there is a very, very wide difference. And some guys are getting all their claims denied, and others are very rarely getting their claims denied, even conditional on what you're billing. Yeah, that's right. Okay, so to wrap up, this is what I want you to take away. First, claim denials are sort of economically interesting, and we actually have to think a little bit about why they're so common, because you would think that people have incentives to weed them out of the system. The second thing is that once you sort of try to write down a model, it turns out that if you think about just explaining this using medical necessity and insurers trying to check for that, that actually can't generate the patterns that we see in the data. While what we say is that fragmented insurance can generate what we see. And also that supports sort of the key findings that we have, which is that denials are widespread, persistent, and commonly predictable, that these denials aren't largely landing on expensive things, but rather cheap things, and that fragmentation among insurers seems to be related to the realization of these claim denials. Now, the last thing I'll say is that if you liked this paper, or if you hated this paper, and if you're working on similar issues, Jetson Later, Luis, and I are organizing an NBER Economics of Healthcare Administration and Fraud conference, the deadline to submit papers of which is tomorrow night, so you should submit and then all come back to Cambridge in October to talk about this sort of stuff. Thank you.
Thank you, Riley. So we have one final break for you to go. paper.
All right, thanks everyone for being here. Really excited to close out a great Health Summer Institute. I'm Eric Eady, I'm a postdoc at Harvard Medical School, and I'm going to talk to you today about vertical integration in the pharmacy benefit market. So what I mean by the pharmacy benefit market is really the process by which we pay for and get drugs from a pharmacy. For me, that usually happens at a CVS. Drugs are expensive, but fortunately I pay Aetna for insurance that covers most of the costs. So I can walk into the pharmacy and hand the pharmacist my Aetna insurance ID card, and while they're filling my prescription, their pharmacy system pings my pharmacy benefit manager Caremark. The PBM is an important intermediary in this market that processes prescription drug claims and also negotiates prices with pharmacies on behalf of my insurer. The PBM pulls out its drug pricing abacus and determines how much it'll pay the pharmacy for the prescription, and also how much I have to pay out of my own pocket. Now, this transaction might all seem ordinary until you realize that the pharmacy, PBM, and insurer involved in this claim are all part of the same CVS Health parent company. This raises some important questions. How is CVS deciding how much to pay themselves for drugs? How is it affecting what I pay out of pocket? And how is all of this changing the premium that I pay to Aetna for drug insurance? Now, as an IO economist, I think that vertical integration like this could be a good thing if it aligns incentives within CVS in a way that results in lower costs. For example, maybe one of the reasons there's high drug prices in the US is because pharmacies like CVS can charge large markups. And those large markups are ultimately costs to insurers like Aetna. So if we combine them into one firm, CVS would internalize that its higher markups would reduce Aetna's profits, and that would lead it to reduce drug prices and costs for the combined firms. This is the theory of the elimination of double marginalization. However, there's increasing concern among policymakers that vertical integration between payers and pharmacies leads to higher drug prices and ultimately harms consumers and competing firms. This has led to numerous investigations of vertically integrated healthcare firms and some recent policy proposals that would force insurers and PBMs to sell off their ownership stakes in pharmacies. Despite these concerns, there's still limited empirical evidence on how vertical integration affects drug prices, insurance premiums, and consumer welfare. So in my job market paper, I'm going to use a structural model of the pharmacy benefit market to understand the effects of vertical integration on these equilibrium outcomes. I'm going to model pharmacy pricing through Nash bargaining between PBMs and pharmacies, insurance premium competition, and consumer demand for both insurance plans and pharmacy services. I'm going to estimate the model using a new data set on vertical relationships in Medicare Part D. I'm going to combine prescription drug claims data from a random 20% sample of enrollees with a new data set on insurer PBM contracts that I obtained through a FOIA request of CMS, and a proprietary data set on pharmacy ownership. By combining these three data sets, I'm going to be able to fully map out vertical integration between all parties in the pharmacy benefit market. I'm going to use my estimated model to understand the effects of vertical integration, including how the incentives of these integrated firms are shaped by government regulations. I'm ultimately going to use my model to simulate the divestiture of pharmacies from insurers and PBMs to quantify the welfare effects of that proposed intervention. So here's what I find. I find that vertical integration incentivizes pharmacies to charge large markups to their integrated payers. This is counter to that standard intuition I told you about the elimination of double marginalization, because of two important institutional features of this market. The first is consumer cost sharing for prescription drugs. When we go to the pharmacy to fill prescriptions, we're required to pay a share of drug prices out of pocket. This creates an opportunity for insurers to earn profits at the pharmacies that they own, even on prescriptions that they're partially insuring, because they can pass on higher prices to consumers through increased out-of-pocket payments. The second feature of this market is a cap on insurance profits called a minimum medical loss ratio requirement. In the US, insurance profits are capped at 15%, but pharmacy profits remain unregulated. Insurers respond to these caps by increasing the prices that they charge at their integrated pharmacies. This strategy allows them to inflate their reported costs to regulators to comply with these profit caps without sacrificing excess profits. Instead, they just move them from their regulated insurance unit to unregulated pharmacies through inflated transfer prices. Unlike the standard vertical supply chain that IO economists are used to studying, integrated firms are setting prices on two demand curves, for pharmacy services and for insurance. Empirically, when consumers choose a plan, they're much more sensitive to premiums than they are to drug prices. And this has important consequences for the pricing strategies of these integrated firms. In equilibrium, their dominant strategy is to reduce premiums to grow their enrollment base, and then make large markups selling them prescription drugs through their integrated pharmacies.
Relative to these internal effects, I find that the competitive effects of vertical integration on competing pharmacies and plans are economically small. The primary reason for that is the presence of these powerful intermediaries called pharmacy benefit managers that negotiate prices with pharmacies. Consistent with anecdotal evidence, I find that PBMs have a ton of leverage in their negotiations with pharmacies, but that their leverage stems not from the ownership of competing pharmacies, but rather from the high degree of concentration in the PBM segment of the market. There are 4 PBMs that process virtually all claims. As a result, there's really no effective vertical integration on the prices that are paid to non-integrated pharmacies, as the scale of these PBMs alone allows them to negotiate prices that are close to the pharmacy's marginal cost. Another competitive concern is that a pharmacy like CVS may seek to exit the networks of rival payers like United Healthcare or Humana in order to reduce their plan's quality pharmacy network and perhaps potentially cause some consumers to switch to Aetna. I find that this form of foreclosure is generally unprofitable for pharmacies like CVS. While it would generate new profits for Aetna, these are small relative to the profits that CVS would have to sacrifice by foreclosing a rival. So in sum, vertical integration is really about internal profit shifting rather than competitive harm. I ultimately used my estimated model to simulate the divestiture of pharmacies from insurers and PBMs, which I find would cause drug prices to decline by 7%, but also cause premiums to rise by 1%. Overall, this divestiture would benefit consumers and also reduce government spending on the Part D program. All right, so here's how the rest of the talk will go. I'll give you some more background and tell you some descriptive facts about vertical integration in Medicare Part D. I'll walk you through a reduced form study of the effects of minimum MLR requirements on the pricing strategies of vertically integrated firms, which has since been carved out of my job market paper into a joint work with Project Akani and some colleagues. Then I'll show you my empirical model, my parameter estimates, and I'll conclude by showing you my counterfactual exercise where I simulate the divestiture of these pharmacies from insurers and PBMs. All right, I'll tell you a little bit about how I want you to think about the flow of funds in this market. I'll preface this by saying this is not going to encompass all of the various firms that participate in the pharmaceutical industry. We're not going to talk about pharmaceutical manufacturers. We're really just going to talk about the way that prices are determined at the pharmacy counter and insurance premiums. So we're used to thinking about pharmacy healthcare markets generally as vertical supply chains. And there definitely is a vertical component of this market. Pharmacies are going to negotiate prices with intermediary pharmacy benefit managers that are going to administer a lot of the key functions of drug insurance on behalf of the health insurers that ultimately sell coverage to consumers. This market isn't truly vertical, though, because consumers are making 2 demand decisions. They're going to choose which plan to buy, and they're going to choose which pharmacy to use to fill prescriptions. Importantly, they're facing prices on both demand curves in the form of premiums and cost sharing for prescription drugs. So understanding the strategic relationship between these 2 prices is going to be important for understanding the incentives of vertically integrated firms. Now, studying vertical integration in this market has been difficult to this point because of a lack of data on where PBMs show up in these markets, and also a lack of data on ownership in the pharmacy benefit supply chain. So to conduct my analysis, I'm going to have to combine 3 sources of data here. My main source of data is going to be administrative data from Medicare. I'm going to see a history of prescription drug claims and plan choices for a random 20% sample of Medicare enrollees. I'm going to merge on a new data set on insurer PBM contracts that I obtained through a FOIA request of CMS. This is going to allow me to identify the PBM that worked for each insurer in Medicare. I also acquired some proprietary data from the National Council of Prescription Drug Plans that's going to allow me to identify the owner of each pharmacy. I did some manual work to identify which of these pharmacies were owned by an insurer or PBM. So by combining these 3 sources of data, I'm going to be able to observe for every claim in the data, the pharmacy that filled the prescription, the PBM that processed the claim, and the insurer that ultimately covered it. And I'm also going to be able to observe the degree of vertical integration between all 3 parties. Yeah?
When I go to the pharmacy, often, right, the pharmacist is like, well, it's going to cost you $100 in your insurance, but if I drop your insurance and give you a coupon for the stack, it'll be $20. Where does data on coupons and that whole end run around insurance fit into all this?
Yeah, it's a good question. So I don't observe coupon utilization in this data. But I can tell you from looking at some industry reports, the use of those coupons and cash pay for the Part D population, I understand, is a bit lower than the younger population. But it's a good question. All right, so using this data, before I get into the model, I'm going to establish a couple stylized facts about vertical integration in this market. The first is that vertically integrated firms play a prominent role at each level of the pharmacy benefit market. Here I'm showing you their combined market shares as pharmacies, PBMs, and insurers in Medicare Part D. Together, they filled 25% of claims as pharmacies, processed over 90% of claims as PBMs, and covered 60% of claims as insurers. Importantly, this PBM segment of the market is really highly concentrated, even relative to these other segments of the market that we usually think about as being really highly concentrated. That's because the same PBM can and often does work for multiple insurers, including insurers that compete with its own integrated plans. For example, Caremark provides PBM services to its integrated insurer Aetna, but also to some of Aetna's competitors. The second stylized fact is that vertically integrated prescription fills are on average more expensive than non-integrated ones. Here I'm just showing you a regression of the log price per day supply of a claim on an indicator for whether the pharmacy was owned by the payer. What I find is that insurers pay higher rates for the same drug to their integrated pharmacies than they do to non-integrated pharmacies. And likewise, pharmacies charge higher prices to their integrated pharmacies than they do, or to integrated payers than they do to non-integrated payers. Again, this is kind of counter to the standard intuition about the elimination of double marginalization, which would predict that these correlations would be negative. So one of the goals of this paper is to identify some of the mechanisms that result in this kind of counterintuitive correlation. So with some co-authors, we identified one regulatory mechanism that results in higher prices for vertically integrated firms. Yeah, Mark.
That's on the total, the list price paid, not the consumers?
That's.
You have this for cost, but the cost sharing amount is the consumer?
I don't have it in the slides, but I should do it in the slides. So yeah, it's close. There's less of a correlation. So what appears to be happening is they said higher gross prices. They compensate a little bit on the cost sharing structure to steer consumers towards the pharmacies. So there's less of a correlation when it comes to consumer cost sharing.
I think it's interesting to emphasize the double marginalization story was about consumer prices.
Right, fair.
Traditional, and so like you're saying, okay, just setting where it's different, you find a different result in the way theory would expect.
Yeah, okay, great.
Do you know what the prices are net of the rebates? I assume this is gross of the rebates.
Yeah, it's a good question. So rebates are a big part of the pharmaceutical industry. Branded drug manufacturers give them back to insurers after the fact. I don't observe the branded drug rebates, they're confidential. So this is everything I'm going to be talking about today is going to be the gross price that's paid to the pharmacy. Yeah, Lee Moore.
Just retail, not mail order?
This is everything. So this includes retail claims, mail order claims. A lot of these insurers and PBMs operate mail order pharmacies that ship drugs directly to your door.
And so when you say vertically integrated, here you mean the insurer owns the pharmacy?
Or the PBM, because the PBM can work for some non-integrated insurer.
So what is your definition of vertical integration?
Here in this, it's whether the pharmacy is owned by either the insurer or PBM. Yeah, insurer / PBM.
And then who owns retail pharmacies besides CVS that is integrated?
There's Rite Aid used to operate an insurer and PBM. I'm not sure if they still do, but
How much is the CVS?
I see. So yeah, so CVS is the biggest insurer, but they deal with lots of different non-integrated payers. Of the fully integrated share, a lot of it is United and Humana and Express Scripts.
But anything that was adjudicated by Caremark and sold to CVS pharmacies?
Yeah, that's right. Yeah. Mhm.
So if you took CVS completely out, that would have been.
Yeah, got it. It would look similar. Yeah. Yes.
Yeah, another dimension of this isn't just the price, but it's also which drugs are included in the formulary. There's arguments that people made that these vertically integrated PBMs are excluding generics in order to just negotiate with the branded drugs and then distributing the rebates and not passing them on. But now with BI, it's internalized with the insurer.
Mm-hmm.
Are you also able to look at like what types of drug, what the generics are excluded, what types of drugs are on the formulary?
Yeah, it's a good question. Are these pharmacies changing the way they dispense drugs? What I've seen in the data is no. They seem to be dispensing generic drugs when they're available at the same rate as non-integrated claims, and they actually make pretty large. They earn a lot more on generic drugs too. So there's not that incentive might be showing up. I don't see it in the data. All right, so with some co-authors, we did some work to identify one regulatory mechanism that might result in these higher prices. And that's the presence of these caps on insurance profits called minimum medical loss ratio requirements. So starting in 2014, the ACA required all Part D plans to maintain a minimum MLR of at least 85%. This meant that insurance profits became capped at 15% in Medicare, but the profits you can earn as a pharmacy remain unregulated. So one strategic response the insurers might have to these policies would be to increase the prices that they charge with their integrated pharmacies, because those claims count towards the numerator of their MLR. So by increasing their internal reimbursement rates, these insurers could comply with the minimum MLR requirements by inflating their reported costs to regulators without sacrificing excess profits. They would just be moved to their unregulated pharmacy subsidiaries. So what we did is we leveraged the introduction of minimum MLR requirements as a natural experiment to test this tunneling hypothesis. What we did was we compared for the same plan, drug, and year, how prices change at integrated pharmacies relative to non-integrated pharmacies after the implementation of minimum MLR requirements. What we found is that insurers increased prices at the pharmacies that they own by roughly 9% following this change in policies. Here we're showing you the effects divided up based on the observed MLRs for plans in the data to show that the price increases were much larger for plans that likely expected these minimum MLR requirements to be binding on their profits. And importantly, these are not just pure transfer prices here. Some of them are going to be borne by consumers through increased out-of-pocket payments. A lot of them are going to be borne by the government, who makes subsidy payments to insurers that are tied to their gross drug expenditures at the pharmacy counter. So this is one mechanism by which vertical integration can increase prices. We're going to do some more work here to identify other mechanisms and to also quantify the effects on premiums and welfare. So, yes?
In that chart, what's the unit of observation? Is it like the market?
It's a plan, yeah, it's a plan pharmacy drug year. So we're collapsing up. Plan is like United Healthcare Bronze. So yeah, the contract ID, plan ID to those who are fluent in Part D claims data. Yeah. Okay, so I'm now going to turn to my structural model of the Part D market, which I'm going to model as a static game in 3 stages. In the first stage, there's going to be simultaneous pharmacy pricing and insurance premium competition. So integrated pharmacies are going to set prices for their integrated payers, while non-integrated pharmacies are going to bargain with PBMs to determine their reimbursement rates. Well, as this is happening, insurers are going to compete a la Nash-Bertrand to determine equilibrium premiums. Then consumers are going to choose an insurance plan, and after doing so, they're going to face stochastic illnesses and have to go to the pharmacy to fill prescriptions. So I'll go through each step now in reverse order, starting with my model of consumer demand for pharmacies, which I'm going to model using a Logit approach, drawing a lot from Amanda Stark and Ashley Swanson's paper. So in reality, prescription drug demand is a 2-stage process. You have to decide what drug you need, and then you have to choose which pharmacy you're going to use to fill the prescription. I'm not going to talk today about prescription drug demand. I'm just going to take your need for a certain statin as given based on a joint decision between you and your doctor. So I'm not going to talk about which drug gets dispensed. I'm just going to model the choice by which you choose which pharmacy to fill the prescription. I'm going to assume that a consumer covered by a given insurer is going to have utility from filling a pharmacy at a pharmacy H. That's a function of the out-of-pocket price I face, as well as my travel distance to get to the pharmacy. So if it's a mail-order pharmacy, like many of these integrated firms own, I don't have to travel at all. The drug just gets shipped right to me. If it's not mail order, I'll have to incur some travel costs to get to the pharmacy. I'm also going to account for whether or not the pharmacy is owned by either your insurer or PBM, potentially because these firms could be steering you towards the pharmacies that they own. Yes?
Feel free to keep this question to somewhere else. But I'm not sure if it's more relevant to the reduced farm work or the structural work, so that's why I'm asking now.
Sure.
So the limiting factor on premiums could be I'm in a competitive market, and so demand is just keeping my premiums low. It could be I want to get LIS enrollees, or it could be the MLRs. And you're really focusing on the MLR part of it, but that's only going to be binding for the set of plans where the other two are not relevant. Have you thought about that heterogeneity? Is it somewhere in the model?
Yeah, so when I estimate my model, I'm going to be considering both low-income consumers and high-income consumers. So the plans are going to be taking into account these differences in payer mix, and they're also going to be taking into account the competitive conditions, right, in their county. So when I model the way that they're setting premiums. I'm going to be talking a lot about MLRs, but I think a lot of those points you're bringing up are going to feed through the model just the way that it's set up. But if you see ways that they're not, would love to talk more. So I'm going to leverage the type 1 extreme value Logit distribution here to write each consumer's expected utility from making a fill through their plan's network. And that's going to be the log sum of the exponentiated utilities of each pharmacy in the network. So this is the same inclusive value we were talking about earlier this morning. I'm going to use this term to express each consumer's willingness to pay for a given plan's pharmacy network. It's going to be the product of the expected number of days supply that you need as a consumer, times your expected utility from making a prescription drug fill. So this is the same willingness to pay measure consumers use to describe the value of a hospital network. I'm going to use this as a characteristic in my plan demand model. So when I'm choosing a plan as a potential Medicare enrollee, I'm choosing between 3 types of insurance. I can buy a prescription drug plan and go through traditional Medicare. I can buy a Medicare Advantage drug plan, or I can forego drug insurance altogether. So I'm going to model this using a nested logit framework, where my utility is going to depend both on the premiums charged by the plan, as well as my expected utility from the plan's pharmacy network. So when I estimate all this, I'm going to allow for these preferences to vary based on my low-income subsidy status, and in some extensions, I'll let it vary based on a measure of your estimated health risk too.
Sorry,
Yeah.
that part, are you thinking about the formularies anywhere with the drugs that are covered? Is that going into the Gamma I?
It's going to go through here. So I'm going to estimate versions of the pharmacy choice separately for each drug formulary tier, the same way that Amanda and Ashley did it. Yeah, so and then I'm going to allow for different gammas for each drug formulary tier. Yeah. All right, so now move on to the supply side of my model. There's going to be 3 types of agents in each county. There's going to be a set of pharmacies H, insurers F, and PBMs K. Pharmacy profits are going to be the sum of plan-specific demands times plan-specific markups over pharmacy marginal costs of filling prescriptions. Insurer profits are a bit more complicated. This first term is going to be the net premium revenues. It's going to be their plan demand times insurance premiums and government subsidy payments, net of non-pharmacy marginal costs. And the second term here is going to be the endogenous portion of marginal costs I'm going to model in the paper. It's the net payments that plans make to pharmacies for prescription drugs. And this is net of the cost-sharing payments made by consumers. I'm going to take as given that each PBM works for a set of insurers in each county. I don't observe how much the PBMs are paid, I just observe who they work for. So I'm going to assume that their objective is to maximize a scaled version of each insurer's profits, where this lambda parameter is going to allow for a PBM like Caremark to place different weights on the profits of its insurer Aetna than it does for some of Aetna's competitors, for which it also provides PBM services. Finally, the objective of a vertically integrated firm is going to be to maximize the weighted joint profits of their insurance unit and their pharmacy unit, where this mu parameter is going to allow them to place a different weight on the profits they earn as a pharmacy. So this is going to be a reduced form way to capture the constraints that are placed on these firms by minimum MLR requirements, which might cause them to value $1 of pharmacy profits more than $1 of insurance profits, because if they earn too much profits as an insurer, they'll have to give some of it back to the government. So I'll show you in a simple simulation exercise how this profit weight affects the premiums and prices charged by these integrated insurers. As you value the profits you earn as a pharmacy more, you're going to increase the prices that you charge at your integrated pharmacies. Now, consumers dislike these higher drug prices. They may switch to different pharmacies in order to get better prices, or they might switch to other plans that offer more generous pharmacy networks. But insurers can counteract this negative demand response by reducing premiums to maintain overall plan enrollment, even though they're offering less generous insurance. Even if we set mu equal to 1, such that the firms are valuing insurance and pharmacy profits equally, they're still charging a markup at their pharmacies in equilibrium. And this markup is motivated by consumer cost sharing, which generates an opportunity for them to earn profits at their pharmacies, even in the absence of these minimum MLR requirements. So to get into the competitive effects of vertical integration, I'll talk a little bit about how prices are determined outside of the integrated firm. I'm going to model this using the same Nash and Nash approach that's been used to model bargaining in the hospital industry and the medical device industry. The price that's negotiated between a PBM K and a pharmacy H is going to solve their Nash bargaining problem. It's the product of the gains from trade from the contract for PBM K and the gains from trade from the contract for pharmacy H, where these terms are raised to the power of these bargaining parameters that capture the bargaining ability of PBMs. Now, in reality, PBMs face some constraints when they're setting up their networks. They have to offer sufficiently broad pharmacy networks, and if they don't, they might face penalties from CMS. I'm going to operationalize that here by assuming that PBMs have to pay a penalty to CMS if they terminate a contract with, say, Walgreens. So I'll show you in a simple toy model how vertical integration changes the gains from trade for these parties when they're negotiating prices. The price that's paid by PBM K to pharmacy chain H is going to depend on the bargaining ability of the PBM. If the PBM doesn't have any bargaining ability, the pharmacy is able to charge the PBM its reservation price. As we give the PBM more bargaining ability, it's able to negotiate the pharmacy down closer to its marginal cost. So this is the base case in which neither party is vertically integrated. Now, how does this change if the PBM owns a competing pharmacy? This is going to increase the opportunity cost for the PBM of working with rival pharmacies. The PBM knows that if it were to terminate that contract, some consumers would switch from using the non-integrated pharmacy to using its own integrated pharmacy. PBMs can leverage this improved outside option to negotiate lower prices with non-integrated pharmacies. But importantly, the added leverage from vertical integration is going to be pretty small if the PBMs are already in a really powerful bargaining position. Now let's consider the flip side, where the pharmacy that's negotiating might also be integrated with a payer. A pharmacy like CVS knows that if it were to terminate its contract with Humana, that would degrade the quality of Humana's pharmacy networks. Some consumers would switch plans in response, and some consumers might essentially follow CVS to Aetna. CVS is able to leverage this improved outside option to negotiate higher prices with external payers. But I find that generally the added leverage for vertical integration for these pharmacies is economically small because foreclosure is really expensive for these pharmacies. It would increase profits for Aetna if some consumers switch, but on average, these profits are really small relative to the profits CVS would sacrifice by exiting a PBM's network because of the high degree of concentration in the payer market. Yes? Yeah.
I've just been, didn't want to interrupt.
Thanks, Leemore. So now you all can see, oh, there were words up there. What I wanted you to take away from this graph is that the competitive effects of vertical integration depend both on consumer preferences, how consumers substitute across plans and pharmacies, which dictates the magnitude of these competitive effects, as well as bargaining ability, which dictates the pass-through of these potential competitive effects to negotiated prices. So with that said, I'll now move on to my one-slide overview of identification of a complex structural model. I'm going to estimate my model of consumer demand for pharmacies. I'm going to identify consumer sensitivity to out-of-pocket prices using variation for the same pharmacy across plans, as well as a set of cost shifter instruments designed to address the endogeneity of prices. I'm going to do the standard Health I/O approach, use these estimates from my pharmacy demand model to compute the willingness to pay for a plan's pharmacy network. I'm going to use that in my plan demand model. Here I'm going to identify premium sensitivity from within insurer variation in premiums, as well as a Houseman IV, the same premium for a plan in different markets, which is pretty standard in this literature. And I'm going to identify the nesting parameter using a discontinuity and Medicare Advantage subsidy design in urban areas as an instrumental variable, again, drawing from Stark and Town. Then I'll move on to my supply side estimation. I'm going to identify this vector of pharmacy profit weights, these MUs, vertically integrated pharmacy marginal costs, and these external profit weights from the optimality condition of pharmacy pricing and premium setting. And then I have everything I need to set up my Nash bargaining model, which I'll use to get these bargaining weights and non-integrated marginal costs. So that's going to be identified here because I'll see the same PBM negotiating with different pharmacies in different years. And I'll see the same pharmacy negotiating with different PBMs in the same year. So that's what's going to give me identification of this Nash bargaining model that's often hard to come by. Yeah, Mark. Yeah.
Between the arms, if there's a soft BI or partial, how are you thinking about that? And does that change across the firm?
So I'll show you when we get there. It's a great question. Is this MU just capturing MLRs or is it capturing something else about firm incentives? I'll show you when I get there that a lot of it does seem to be firm incentives. You know, the MLRs, when they're set in Medicare, end up being non-binding for a lot of plans. So what these MUs end up, I think, being predominantly is something that reflects what you were asking about, which is these firm incentives. Yeah. Way less complicated than what Chris had to do. So here it's pretty easy. The pharmacies are just owned by, so like Optum, United Healthcare's pharmacy is Optum Rx pharmacy. There's a lot less partial ownership in pharmacy than there is in medical providers. Yeah. All right, here are my estimates of consumer preferences for pharmacies, which I'm showing you separately here based on drug formulary tier, which is going to be a way to account for some differences across drug classes. I'm also showing them separately based on the low-income subsidy status of consumers. I find that consumers are sensitive to out-of-pocket prices. I also find they're more likely to use the pharmacies that are owned by their insurer or PBM. So I'm going to use these estimates, compute each consumer's willingness to pay for a plan's pharmacy network. I'm going to use this as a characteristic in this plan demand model. Yeah, Mark. So they do face some in the deductible. So there is some exposure to these prices for the low-income guys. If you were to compute the elasticity, their elasticity would look lower as a result. Yeah. Yeah.
So what is the elasticity? And is it the same thing Swanson might get?
I should double check and put it back in there. I think I've double checked and it's close. Yeah. So these are my estimates of consumer preferences for plan characteristics. The important thing here is that consumers are roughly 3 times more sensitive to premiums than they are to their expected utility of the pharmacy networks when choosing plans. This is something that's been documented by lots of people in this room, that people are more sensitive to premiums than they are to expected out-of-pocket payments when choosing a plan. Here, in my case, this is going to have important consequences for the pricing strategies of these equilibrium firms, of these integrated firms. They're going to internalize that they can offset large increases in drug prices with relatively small reductions in premiums. No, please. Yeah.
Sometimes willingness to pay on the sort of inclusive value formula can be biased downwards because of measurement error.
Mm-hmm.
So when you thought about putting like something about, does this plan cover the person's actual pharmacy they've been using in the past?
So using their historical, yeah.
I found and others have found in like hospital event systems that sometimes the inclusive value is just really noisy. It's filtered through this massive structural model.
Sure.
You just have a dummy for whether it covers, you know, a pharmacy you've been using. That load's a big amount of willing to pay.
Okay, great. Thanks. Would love to talk more about that, other ideas that you could have to address that. I'll show you a subset of my supply parameter estimates for 2017. Importantly, I find that PBM bargaining ability is close to 1 on average, which means that PBMs are negotiating prices that are close to marginal cost on average. So non-integrated pharmacies like Walgreens are in margins of roughly 15%, which is in line with industry averages, but integrated pharmacies earn margins that are roughly double that or more. So what appears to be happening is that PBMs are effective at controlling drug prices at the pharmacies that they don't own through bargaining, but minimum MLR requirements and cost sharing are weakening incentives for them to control costs internally. And to speak to Mark's point, we do see some differences in the weight that firms place on their pharmacy profits that are potentially consistent with these different firm incentives. So CVS and Express Scripts place a higher weight on their pharmacies. These are legacy pharmacies that integrated into insurance and PBM work. Humana and United are legacy insurers that started operating healthcare providers, and we can see they place slightly less weight on the profits they earn as pharmacies, but they still earn very large markups at their integrated pharmacies based on my model estimates. So vertically integrated pharmacies earn larger markups. Yes, Ben? Okay. But this could still be welfare enhancing because we know that vertical integration also incentivizes them to reduce premiums. So to quantify the welfare effects of vertical integration, I'm going to use these estimates to simulate how equilibrium and outcomes would change if pharmacies were divested from insurers and PBMs. So in this counterfactual, formally integrated pharmacies now need to bargain with these powerful intermediaries that are effective at controlling prices through bargaining. PBMs are able to negotiate down prices at the pharmacies that they used to own by over 50%. Well, this divestiture eliminates some of those anti-competitive incentives that are faced by PBMs. It doesn't change the fact that non-integrated pharmacies are still at a major bargaining disadvantage when negotiating prices with PBMs. And as a result, the prices that are paid to non-integrated pharmacies barely increases. Overall, I find that the divestiture reduces drug prices in Medicare by 7%. This is going to directly benefit consumers who face lower out-of-pocket prices when they're filling prescriptions. It's also going to cause them to view insurance plans as offering more generous pharmacy networks. So their value of the willingness to pay to pharmacy networks is going to increase, particularly for these formerly integrated plans.
In the last simulation, what happens if you take out the MLR?
I haven't done that yet, but I should do that. That's something that's on my to-do list. So the next version of this will have a simulation where we pull that out of the solver. Without this incentive to cross-subsidize these pharmacies, formerly integrated plans end up increasing premiums slightly. Non-integrated plans actually have a small reduction in premiums, which is a bit surprising because their rivals are raising premiums, but their rivals are also offering much more generous insurance here. So to compete with these higher quality, higher priced plans, these non-integrated plans end up reducing premiums slightly. Overall, I find that consumer welfare increases by 8% as a result of this divestiture. There are 2 groups that experience exceptionally large gains from this divestiture. Rural consumers, who typically have limited options for filling prescriptions outside of the pharmacies that are owned by their insurer or PBM. So they really benefit from having lower prices at these pharmacies because they have fewer options to turn to. Low-income consumers use a lot more prescription drugs, so they also benefit more. My simulation reveals that this divestiture would also reduce government spending on the Part D program. I do a back of the envelope exercise here to simulate how some subsidy payments would change in response to this divestiture, ultimately find that the divestiture would reduce Part D spending by $5-obscured billion, roughly 7%. And a lot of this is through reductions in subsidy payments to insurers that are tied to their gross drug prices. So to conclude, I find that vertical integration between payers and pharmacies leads to higher drug prices that is only partially offset by lower premiums. This harms consumers and ultimately increases government spending on healthcare and Medicare Part D. One of the key takeaways here is that the effects of vertical integration in insurance markets are unique when compared to the standard vertical supply chain that we're used to studying, because firms are setting prices on two demand curves, for insurance services and for pharmacy. Importantly, the relative elasticities of demand in these market segments, combined with regulations that change the profitability of selling insurance relative to selling drugs, ultimately dictates the pricing strategies of these firms. I'm done a little bit early, but thanks so much for being here. Really appreciate it and happy to talk about everything.
Thank you, everyone, for a great meeting. Eric will be up here to take your further discussions. If you have any feedback, please come send Amy or myself an email, and get home safe. Thank you so much.